indicates that states are generally happy with and continue to pursue full risk managed care. Also want to remind you about the goals of Georgia Families. This is something that we have on the walls in our offices, and we look at these every day because these truly are what drive us. We wanted to improve the health care status of our population. We wanted to establish contractual accountability for access to and the quality of health care. That's really important. We've not had a contractual accountability before. We still feel like that is one of the most important things that Georgia Families brings to the state. We wanted to lower our costs through more effective utilization management, and we wanted to have budget predictability and administrative simplicity for the department. So just remind you of those goals. And then from those goals spring our objectives. Again, improving our health care status of our members. We do this program for our members. They are the ones that Georgia Families, that program exists for. Providing their health care and improving their outcomes is what we live for every day. We felt like it was very important to continue to work on establishing medical homes for members through the use of either a selected or an assigned primary care physician. We support that notion, as do our 3 plans. We also wanted to flesh out that notion of contractual accountability between the department and our vendors, our CMOs, and the participating healthcare providers. We wanted to slow that rate of financial expenditures while providing quality care. And really, very importantly, and this is a real challenge, we wanted to expand and strengthen a sense of healthcare, of member responsibility about their own health care. The notion of consumerism, personal responsibility in health care is a notion that's taken off across the country for all of us. And with the Medicaid population, you have to start with baby steps. And that was one of the things that we really wanted to begin to do with Georgia Families, is to start working on that notion of personal responsibility. And that starts with the knowledge of how to take care of yourself and having choice. So having reminded you of the past and how we got to where we are and what our goals and objectives are, I want to take a minute to talk to you a little bit about the things that we feel are like our achievements in the past year. Certainly that any type of change of this magnitude is a challenge for all parties involved. There is no question that it has been traumatic in some respects, but I do want to point out these truly what I feel like are achievements. Also to remind you who are the members that are in Georgia Families. Our entire Medicaid population is not covered by this program. In Georgia Families are Medicaid members who are covered under the low-income Medicaid or TANF program, the RSM right from the start, who are pregnant moms, Peach Care for Kids, also refugees, which is a very small category of eligibility, really people who are here pretty much under a political asylum, and women who are covered because of breast and cervical cancer. So remind you that we had divided the state into 6 regions for purposes of the implementation. We moved 950,000 members into their regionalized CMOs in the space of about 4 months. That's a huge achievement. And I will also remind you that in 2003, we had another big transition. Members in the audience who are providers will know that that was difficult and challenging, to say the least. Certainly worked through those challenges, but we all knew, and one of the pressures on us to make this happen correctly and right was that we didn't want that to happen again. So in spite of everything else that might have been an issue, we did move 950,000 people into managed care organizations in the space of about 4 months. Claims were paid, people got care, and that is an achievement. Just to focus a little bit on the things that I talked about member knowledge and responsibility. For the first time, our Medicaid members are choosing their health plans. Sometimes they're making that choice based on the added benefits that the plans offer. We've not been able to do that in the traditional fee-for-service world, and our plan choice rates right now are exceeding 80%. We think that that's a huge step and a huge benefit for our members to have choice, to make a choice about how their health care is delivered. We also, again, are very much supportive of the notion of a primary care provider. We want our members to choose primary care providers at the same time that they choose their plans. However, frequently they're coming onto Medicaid, they're new, they don't have that provider, so our choice of PCP from the beginning is less than the choice of plans. However, once they get enrolled in their plans are putting them with primary care providers. We feel like that our CMO, their member outreach and education activities are a huge plus. The education materials, their case management, their member outreach activities, these all reinforce their healthier lifestyles, and we feel like that ultimately is going to lead to a healthier population. Again, these have been resource issues for the department. We've had neither the people or the financial resources to do member outreach and education. A number of years ago, when I first came to the department, one of the things that I wanted to be able to do on some type of small scale was to be able to start doing that member outreach. I got $500,000 to do outreach to over 1 million members as a postage stamp. I couldn't even get the postcard for that. So this is a real benefit that has been brought to the Georgia Families Program. In addition, our CMOs are out in the communities. They partner with community organizations. They partner with churches, with schools, Boys and Girls Clubs, Head Start programs. They're out there. They're engaging our members at where they live. They're at community events, at churches, supermarkets, schools, DFACS offices. Again, we think that's a great benefit brought to our members. In addition, the communication is appropriate for our membership. We feel very strongly that part of strengthening their responsibility for their health care is making sure that the information that they receive is tailored to their needs and abilities. In the realm of clinical care, and I'm going to try not to steal the thunder. Dr. Dave Neer is here with me today. He's our clinical director, and he's going to talk to you about our clinical and quality programs, because that's something that you've not heard a lot about, and we want you to hear about it because we feel like there is a huge focus on that you've not heard about in the whole implementation activities that have been going on the last year. So, Dave, I'm going to try not to steal any of your thunder. But another benefit that we believe is just tremendous for our members is implementation of case and disease management programs. Remember that this population, while we have this for our age-blind and disabled, we've not had this available for low-income, for right from the start, and for Peach Care members. We have disease management programs now for asthma and diabetes in all 3 of the plans. They also all do case management for prenatal care, complex cases, and anyone with developmental delay. They also, all 3 of the CMOs, because we have put a contractual requirement upon them that they become accredited by either NCQA or one of the other national accrediting organizations, they have to perform annual member satisfaction surveys. Those are the CAPS reports. Again, this is the first time our members have really been surveyed about the receipt of their health care and how they feel about that. I think that all 3 of the plans are going to, tomorrow when they report to you on their own particular activities, we'll talk to you a little bit about that, but the preliminary results show a high level of satisfaction from the members, particularly around children's services. Again, we think this is a good thing for our members. And another issue that is particularly compelling for providers, you will hear from hospital providers about this. This is a concern of theirs and a genuine concern. We don't discount that. We have known for years that there's a high degree of inappropriate ER utilization in our Medicaid membership that drives costs. It is not unique to Georgia. Every state that has a Medicaid population, which is all of them, struggles with that, and that's to get members out of that very expensive setting and back to a primary care provider. There are many activities going on. Some of the high volumes facilities have particular arrangements with the CMOs where the CMOs are alerted if their members have been there. The CMOs reach out to that member, educate them about when it really is appropriate to go to the emergency room, try to reconnect them with the PCP, offer transportation if necessary. They're working with providers who have urgent care clinics to bring those into the networks, also working with PCPs about possibly expanding their office hours into the evening. And they're also following up with PCPs because some part of the issue is that there are some PCPs who routinely direct people to the emergency room rather than see them in their offices. And then also, again, following that notion, some of the CMOs are looking at those high-volume PCPs and doing outreach to them if they are seeing any type of practice patterns that are outside norms, high ER utilization, high pharmacy costs. And then overall, I'll just remind you again, this was a very large-scale implementation. No state, while most every state has some type of Medicaid managed care, as it is with most states. When you've seen one Medicaid program, you've seen one Medicaid managed program, care program. Again, we had a very large-scale implementation in a short period of time, a lot of different complex interfaces. We learned from other states. We had a huge amount of collaboration amongst all the partners. That's the 3 CMOs, Maximus, who is our enrollment vendor, ACS, who's our fiscal intermediary, the department, PSI, all the different PBMs. Everybody made a Herculean effort to make all of this happen successfully. Also because of the reporting that the plans have had to do to us, and we'll go into a little bit about how much reporting they have to do, and they love me for all the reports that they owe to me on a regular basis. We've been able to substantiate their statewide provider networks, both in urban and rural areas. We continue to monitor those. We've had some very good open communication with provider associations. Starting back last summer during the implementation, we had regular communication with the Georgia Hospital Association, the Georgia chapter of the American Academy of Pediatrics, the Georgia Academy of Family Physicians. We still meet regularly with them, and while we don't always love what they say to us, they have provided some very good feedback to us, and we welcome that, and they certainly have helped us try to make this program better. We also have very good communication and collaboration with the Georgia Department of Insurance. Remember that these 3 MOs are licensed and regulated by the Department of Insurance, so that there is not only the Department of Community Health providing monitoring and oversight, there's also Department of Insurance. Just again to remind you that these 3 CMOs have contractual accountability to us for the access and quality of health care. Their contractual requirements are centered around different areas. They have different contractual requirements for member services and activities. They have requirements about adequacy of provider networks and the type of services that they need to provide to providers, including claims payment. They have huge requirements about clinical and quality programs, again, that Dr. Nair is going to talk to you about. We have requirements on them about financial solvency as well as IT capabilities. So really want to talk to you today as we've moved out of our implementation year into how we monitor and oversee these plans on an ongoing basis, knowing that there's a huge amount of interest. I mean, we pay a lot of money to these plans, and they have the responsibility for the health care of almost 1 million of our members. I wanted you to understand today that of our activities and how involved we are in making sure that these plans live up to these. We monitor their compliance with a number of different ways. As I said, they have a pretty high amount of report submission to us. I actually counted them up, and they have 58 required reports that they have to submit to us on weekly, monthly, quarterly, and an annual basis. These are our reports about member information, network information, geo-access reports, prior authorization and utilization management reports, financial reporting, pharmacy data, claims payment information, EPSDT reports, member and provider services with their call centers, grievance and appeals, business continuity, disaster recovery plans, system refresh plans, SAS 70. So it runs the gamut, soup to nuts. And we don't just sit and check these off on a checklist when they come in. We actively follow these. My staff assesses what's contained in those, issues corrective action plans if necessary, follows up on those if necessary. It's a lot of information, and we're in their business all the time. There's also a huge amount of interaction between the Managed Care and Quality Division staff and CMO staff. We have regular meetings at all staff levels. I meet, and for a long time I met weekly with the CEOs and COOs. We now have gone to every other week, but the medical directors and quality directors meet with Dr. Nair on a regular basis. My provider relations director is out in the field meeting with her counterparts and traveling with them. Same thing with member services. So there's a huge amount of on-site monitoring going on between us and the plans. We also, as I mentioned to you, have regular DCH communication and collaboration with the Department of Insurance. They have joined us in some of our auditing activities. We do have a rather large-scale claims audit planned that should begin in the next few weeks, and Department of Insurance is working with us on that. And again, also the communication that we get from the professional associations also helps us. We're just not necessarily hearing from the plans. We also solicit feedback and input from provider associations and providers. And as I said, it's not always roses, but it's critical for us to get that feedback as well. My particular division, the Division of Managed Care and Quality, our role is to monitor that performance and oversee their activities. We're divided up into units that focus on the different areas of the contract. So you see member services unit, provider services, quality, and contract. Just kind of go through for you what each of those units do on a regular basis. Our member services unit participates in monitoring the call centers of all of them. All three of the plans are required to have both member and provider call centers where members and providers can call in during specified time to get information that they need. We monitor and make sure that they are compliant with our requirements for speed to answer, abandonment rate, and other requirements. And that staff watches for they monitor for any trending. They are watching that over time. If they see anything, any dips, they will issue corrective action plans and follow up on that. I'm happy to report that those service levels have remained extremely high, even during the implementation time periods. All three of the plans are required to have websites that both members and providers can access for information. My staff monitors those websites to make sure that that information is up to date and accurate. And the member services staff, one of the things that I mentioned to you that's a benefit is having this education and outreach material, and that it's also appropriate for our members. For example, the reading level of any type of member education material has to be at a 5th grade level, so that when we review and approve this, we have software that we are making sure that monitors that 5th grade reading level. All the plans have to have their information available in Spanish and other languages. Also, they have to have hearing and vision impaired versions as well. So that's something that we're reviewing and approving on a constant basis. Any change to any member material has to be submitted to us and then approved by us. My provider services unit is out there in the field constantly. They are at every educational activity that a CMO has at a hospital or any type of gathering. There's someone from my staff there monitoring what they're saying. They ride with them, the provider services reps, when they're going out and doing calls on provider offices. In addition, my staff goes alone to offices. We solicit information from physician offices about what kind of service are you getting? How would you rate these? Are they responsive to you? What kind of feedback do you get? Do they resolve your issues in a timely manner? That staff looks at their websites. Because the provider networks are available on the websites, we monitor that on a very regular basis to make sure that that's updated and very current. We also, one of the things that that the plans have to submit to us is reports. They have to assess from their provider network on appointment wait times. We don't just receive those reports, we're actually calling behind. I have staff that do what we call secret shopping and calling provider offices to verify how long it would take to get an appointment and what's the appointment availability. We review their policies and procedures and their provider manuals to make sure that they are updated so that providers have the most up-to-date information in their hands about what are the rules here. The geo-access reports are something that are submitted to us. They're very crucial. Those help us assess the network availability. They're submitted to us. In the first year, they were submitted on a monthly basis. Now we've gone to quarterly, but those are something that we assess. And again, there are areas of the state where we still have some issues and some challenges with access. I know that one of the things that, go ahead. One of the things that was of some interest to you is actual numbers of providers. Was somewhat hesitant how to show this to you because in some respects trying to make sure that there's an apples-to-apples comparison was a challenge here. We enroll providers in Medicaid by category of service. That's not something, that's not a technique or a method of provider enrollment that is used traditionally out there with commercial or with Medicaid HMOs. So trying to make sure that I'm counting providers and comparing that to what the plans have was a little bit of a challenge. But I did want you to see here that in the fee-for-service world, statewide throughout Georgia, that primary care provider locations, and that includes pediatrics, is 1,546, and that is current. Now, we actually have more enrolled than that, but these are current, meaning these are providers who have filed claims within the last year. If a provider on the fee-for-service side does not file a claim for a period of time, they become inactive. So that 1,546 represents active providers. Of course, that is smaller now than most of the people that were in Georgia Better Healthcare have moved over to CMOs. We have 18,659 specialists as well as 265 hospitals. A point I need to make there is there are not 265 hospitals in the state of Georgia. However, we do enroll on the fee-for-service side any provider who is within 50 miles of the state's borders as a Georgia Medicaid provider. So those counts will be a little bit inflated because of that. Now you can see just the raw numbers on the three plans. Would remind you that AmeriGroup is in 4 regions: Northeast, Southeast, and the Atlanta region. Peach State is in 3 regions, and then WellCare is in all 6 or statewide regions. So you can see there the numbers, the comparison. I know that's been a concern that there have been declines in access, certainly a concern for us, and we do monitor that on a very close basis. Quality oversight, there's a huge amount of analysis and trending of the quality reports. You have listed here some of the reports that they receive on a regular basis. You also know that we do audits to make sure they're in compliance with state and federal regulations. We do that by site visits where we're looking at their processes, and I think you're all aware that we performed an audit with all 3 plans on the timeliness of their prior authorizations. We'll continue to monitor those. We do desk reviews over their policies and procedures. Our quality unit also has regular meetings to receive updates, share information, and those are meetings with the CMOs, again, with their medical directors. They meet with professional societies, sister agencies, DHR, national and federal organizations, and other state Medicaid quality departments. They're very engaged with some of the other states with their quality measures. My contract management unit is responsible for just overseeing compliance overall with the contract. One of the most important things that they do is coordinate communication between the plans and various divisions within the Department of Community Health. One of the things, the benefits that we think this program has brought is that there's a great deal of shared information and collaboration between the 3 CMOs and our program integrity units, as well as our third-party liability. We feel like that if there's an issue there with a provider, then it's going to be an issue with all three of the CMOs as well as fee-for-service, so we do share information. Third-party liability, obviously Medicaid's the payer of last resort, so if one of the plans finds out that there's a primary payer, certainly sharing that information is important. My contract management unit receives and distributes all of these deliverables that we have to approve. They are following the compliance with state and federal law, and they're assessing them and tracking their performance against these requirements. They also are kind of like the point of response for concerns with the contractors, and they also communicate the corrective action plans and liquidated damages if we need to assess those. For claims and financial oversight, our division monitors claims payment to providers as well as their financial performance and stability through the following activities. All three of the CMOs have to file monthly claims reports to us about timeliness of payment, claims denial rates, reasons for claims denials, and the amount of money paid out. We can also request ad hoc reports if any type of issue comes to us through the various provider associations, and we have done that on several occasions. We've heard of issues popping up, and we have requested that in order to deal with those. One of the things that as I said, we share information with the Department of Insurance. The Department of Insurance has also done some analysis of timeliness of claims payment, and while their formal report has not been released yet, they are finding very good results from that. We have biweekly conference calls between us and each one of the CMOs, including a senior manager level, and those discussions center around any issues that have come to us through providers, and also having to do with any timeliness issues that we see. Any performance issues that we see coming up in claims payment are addressed on those conference calls. We also do a monthly performance report card that we share with the Care Management Committee of the DCH Board, and we're giving them some metrics in claims payments, customer service, utilization management, and we're going to grow those over time. Again, we're adding measures to that over time. As I said, we are doing an independent claims audit. We have contracted with a national CPA firm, Myers & Stauffer, with input and collaboration from the Department of Insurance to perform an audit on all three of the CMOs. That will start very shortly, and they will look at the payment processes of all three of the CMOs. And I know that's something that is people are very interested in. Going back to the Department of Insurance requires the CMOs to file quarterly claims reports with them, documenting their compliance with Georgia's prompt payment law. And then we also want to see monthly reports detailing amounts paid by medical service line, by type of service, and what percentage of their revenue. And then they have quarterly and annual financial statements that they also must file with the Department of Insurance, which DOI shares with us. This is just the most recent, very high-level claims payment issues. Just some statistics on that. 18.6 million received in claims, and this was through June. 16.2 million paid out. That's about an 87% payment rate, and that means about a 13% non-payment rate. At that point, I would remind you that in the fee-for-service world, that we were denying 15 to 20% of claims in the traditional fee-for-service world, so that's not too dissimilar from that. Aggregated with all three plans, their clean claims adjudicated within 15 working days, 98.7%. And then at the bottom, you see the average days to adjudicate a claim. June through December last year, during the implementation period, did have some issues. That has come down, thank goodness, and we are monitoring that very closely. That's the end of the formal part of my presentation. I did want to also tell you and acknowledge that while I feel like that we have made a lot of achievements in this program, I certainly don't want to gloss over the fact that there are opportunities for improvement all the way around, that there are issues that we are continuing to monitor. touch on a little of those. I think that you will hear those from some of the folks who have come to give testimony today. Certainly, provider access is a huge issue. It's a great concern for the department. It's a great concern for the plans. They are contractually obligated to provide me a network that meets certain geographic access requirements. There are some parts of the state that, even under the best of circumstances, that would be a challenge to meet. There are some parts of the state in very rural areas that there are just some provider types who are not there. That continues. Nonetheless, I continue to hold the plans accountable for providing that. We have had issues with some of the pediatric specialists, in particular orthopedics, endocrinology, neurology, and dermatology. There are not a lot of those guys out there, and they drive a hard bargain. Nonetheless, we have to have them in the networks. The plans, the CMOs, are not required to follow Medicaid policy. They don't have to do things exactly the way we've always done them. That's not a contractual requirement. However, most all of them have chosen to follow it very closely and mimic it in some areas. We have had some real challenges ongoing to clarify for them exactly what do we mean in our Medicaid policy. If any of you have ever, and if you ever have any insomnia, I would highly recommend that you read one of our Medicaid policy manuals. It puts you right to sleep. So trying to clarify for the plans what we really mean by that policy so that they can implement it in their systems is an ongoing challenge. We just had a meeting about 2 weeks ago with our hospital policy staff and all folks from the CMOs. They had, over the course of the last year, some questions had come up that definitely needed clarification. We also have challenges with provider loading, making sure that once a provider contracts with a plan, that contract and that provider gets loaded and configured in their system so that claims can pay. And there have definitely been times when that's backed up at one plan or another, and we continue to monitor that, making sure that trying to get those providers in the system as quickly as possible. One of the things that we have found through this that is a continuing challenge is that it is in Medicaid policy that providers have location-specific ID numbers, so that if I'm a physician but I have 3 offices, I'm required by policy to have 3 different Medicaid ID numbers. And we require that of the plans. We have told them in the contract, you may not bring a provider into your network until they are a Medicaid provider. As they've been out over the last couple of years contracting, they found many circumstances where providers have just not ever bothered to get those additional location numbers. While it's our policy, it's not something that we're actively out there policing. So that has caused issues, frustration all the way around, because in a situation like that, we've got to go ahead and get that Medicaid provider number for that additional location. It has led to some delays, there's no question about it. We have issues with newborns. One of the things that we have a challenge with, and this predates managed care, is trying to get those babies into the system with a Medicaid number as quickly as possible so that we can recognize them, we can hook them up with a primary care provider as quickly as possible, and that continues to be a challenge under Medicaid. We're going to continue to work on that, though, to try to get that, to make that as best we possibly can. I will think I have achieved a huge success if we can get 90% of babies enrolled within a week or so of birth so that they can be hooked to primary care providers. We think that's very important, and we know providers are frustrated by that as well. We are getting the encounters from the plans. I think everybody is very interested in that. We're going to use those encounters for a number of different purposes. However, it is a somewhat time-consuming process because we're actually receiving right now, we've got to get brought up to date from all the encounters back to June the 1st of last year. So that is taking some time, and I know that people are wanting to get out there and look in that data and play in that data, nobody more so than us, but it is taking some time for that. So we have a number of things that we're still working on, but we feel like that we've come a long way. We feel like that the benefit to the state is still huge, and certainly to our members, and we're going to kind of continue to try to make this program run the best that we possibly can. That's my story, and I'm sticking to it. So I'll be happy to answer questions. And then Dave, I think, is going to do his presentation.
We're going to go ahead and
You go ahead and let Dave do his
presentation, then we'll
Okay.
have questions afterwards.
That's fine
You'll
for me.
introduce your next guest.
Good morning, Chairman Goggins, Chairman Chanel, members of the committee. Thank you for having us here today to speak and talk to you about the managed care program. As Kathy had mentioned, part of what I'm going to talk to you about today are the clinical and quality programs, our oversight of those programs at the managed care companies. And I think specifically going back to the managed care goals that Kathy had mentioned, what I'm going to focus on are goals of improving healthcare status of the members and lower costs, but through promoting more appropriate utilization management. One of the things I wanted to talk about is go back a little bit to some of the reasons why we implemented a managed Medicaid program. And despite having many very high quality providers and hospitals within the state of Georgia, when you look at national health outcome data, one of the things that you see is that Georgia typically ranks fairly low in terms of some of these national measures. Part of what we have up here, and this is data from 2004, it's statewide data, so it's not just Medicaid data, but it's statewide data. And if looking at things in terms of infant mortality, low birth weight, Georgia ranked 44th within the country in terms of our rates for those outcomes. Preterm births at 12.8% of all births being preterm, we're 32nd. Prenatal care, this is the percentage of women that get prenatal care beginning in their first trimester. We're not doing too bad there, 84%. It's about right in the middle of the pack. But these are some of the things that we want the CMOs to address. Again, if we look at healthcare services, one of the things that we will be comparing ourselves to are HEDIS measures. HEDIS is the Health Employer Data Information Set. And these are standard measures that are compiled by NCQA, the National Committee for Quality Assurance. And they provide a mechanism for payers of healthcare services, members of healthcare plans, to compare different plans and how they perform in various preventive services and quality of care measures. And if we look at some of these are just examples of some of the measures that we'll be looking at. But well child visits, that's the percentage of children that get at least 6 visits within the first 15 months of life. This is Georgia Medicaid data from fiscal year 2006, so it's the 12 months immediately preceding managed care. So at that point, 48% of the children in our population received at least 6 visits within the first 15 months of life. And that we're just below the 50th percentile of all HEDIS plans. Now, HEDIS breaks out their measures for benchmarking purposes between Medicaid plans, commercial plans, and Medicare plans. So the data that we have up here are Medicaid-specific data. Adult preventive care, we're looking there at the percentage of adults that get at least one preventive health visit within a 12-month period. 79%, again, right about at the 50th percentile compared to other Medicaid plans. Asthma treatment is looking at the percentage of members that have asthma who are receiving appropriate medications. Doing a little bit better there at 88% and right in between the 50th and the 75th percentile. And then finally on this chart, diabetes. And this is a measure of the percentage of members that received a hemoglobin A1C test within a year. And that's a measure of how well controlled their glucose levels are. And here we did not do so well with only 65% of our Medicaid members receiving this test, and that's well below the 50th percentile. Now, I know one of the things that everybody is looking for and has been asking us about is, okay, we're a year into managed care. How are the CMOs doing? How do we look? Have they improved healthcare outcomes? What do the numbers look like? And unfortunately, we can't yet tell you that. Because a lot of these measures require 12 months worth of data, and because when you look at full statewide implementation of October of last year, and then allowing for some period of claim lag, usually about 3 to 4 months to know that you've got at least 80–90% of your claims in, we're expecting to have some initial results on these measures in early 2008. The other point I wanted to make is when you look at other states that have shifted to managed Medicaid, part of what they'll tell you is the first year is pretty much a baseline year, not to expect to see improvements during this time. And for the most part, when we've looked at other states, they're usually seeing improvements in clinical care measures and outcomes within 3 to 5 years. So I think as we start to look at this data, we want to look at that in terms of benchmarks and what to expect. What I'm going to talk to you a little bit about right now is some of the program design, contractual requirements, and how we're monitoring the clinical care and quality of service provided to members. Some of this is probably just reminders, but the CMOs are required to provide services that are currently covered by Medicaid. No benefits have been eliminated. If it's a benefit under fee-for-service, it's a benefit under managed care. There are some that they may have added as benefits. CMOs are expected to manage utilization and authorize medically necessary care. They're expected to promote increased access to and utilization of primary and preventive care. And this is one of the main things we're looking to them to do. And they're expected to develop disease and case management programs to improve the care of special populations, such as asthma, diabetes, chronic kidney disease, pregnancy. Under our contract, we require that the CMOs require prior authorization for all non-urgent, non-emergent inpatient admissions. Similarly, we require that they may not use prior authorization as a mechanism of looking at emergent services or urgent care services. For any other services, the CMOs can decide whether or not a specific service needs prior authorization. So each of them, there may be some services that one requires prior auth that another does not. When they do require prior authorization, they are required to make a decision on that request within 14 calendar days. The exception to that would be services where the provider or the CMO thinks that making a decision within that time frame could seriously jeopardize a member's health or life, in which case they're required to make that determination within 24 hours. And Ms. Driggers had mentioned some of the ways that we've audited their timeliness for that. Prior authorization is primarily a mechanism to look at the medical necessity of care. We do allow each of the CMOs to use their own medical necessity guidelines. However, those guidelines must be consistent with and conform with the Georgia State requirements for medical necessity. And some of those points are that the treatment is appropriate and consistent with the diagnosis of the patient, and omission of that treatment could adversely impact the health condition. It's compatible with standards of acceptable medical practice, provided in a safe, appropriate, cost-effective environment. It's not provided solely for convenience, and it's not primarily custodial unless that custodial care is a covered benefit. And all these decisions are made by a physician. In the instance where a CMO may decide medical care is not medically necessary, they may issue a denial. In the case that they do that, they're required to conform to federal and state guidelines. They must allow the member an opportunity to appeal that determination. There's one level of appeal with the CMO. A second level, if the CMO upholds their determination, the member can file an appeal with an administrative law judge. In terms of our oversight of these services, some of what we look at are prior authorization reports, and we're looking at timeliness of those authorization determinations. We're looking at utilization management reports, so trends in utilization, things like admissions per 1,000, days per 1,000. We're looking at denial rates. Partly what we're looking for is to monitor for trends of either over or underutilization. Certainly with capitated plans, we're going to be concerned about potential underutilization. To this point, we have not seen data that indicates that. We're looking at CMO record audits, and so far we've conducted audits on their prior authorization files and their denial files. And we're also reviewing member and provider complaints, and this cues us into potential problems in their authorization management systems. Now, in terms of maintaining or looking at appropriate utilization, it's not just a matter of approving or denying care. Part of what we're looking to the CMOs to do is to look at potentially preventable hospitalizations. And these are conditions where appropriate management on an outpatient basis is going to be more likely to decrease complications and therefore reduce the likelihood that somebody will require inpatient care. So some of these conditions are things like asthma, diabetes, low birth weight, or readmissions from an earlier hospital stay. Some of the interventions that the CMOs may be doing to address preventable hospitalizations are things like their disease management programs, perinatal case management programs, discharge planning and case management to make sure that people are getting appropriate, timely care when they leave a hospital, and then also making sure that members are connected with a medical home and that they're receiving appropriate preventive care. Some of the contractual requirements for these areas of disease management, case management. As mentioned before, the CMOs are required to have disease management programs for asthma, diabetes, and then they must also have at least 2 more programs in the areas of either perinatal care, obesity, hypertension, sickle cell, or HIV. They're also required to have case management programs for infants or toddlers with developmental delay. I'm sorry, I think a couple of slides in the printed handout were out of order. Apology for that. Infants and toddlers with developmental delay, pregnant women who are under 21 and therefore more likely to have adverse outcomes, and also children who have high blood levels. They must have case management programs for at least these, and in most cases they have additional programs as well. Disease management, again, is primarily a system that's focused on coordinated healthcare interventions and education for people with a specific condition or disease. The way the CMOs are doing this is they'll have various ways of identifying people that have a condition such as asthma. This could be based on their claim data, a request from a member or a provider to be enrolled in that program. And what they will do is stratify these members based on risk, looking from low to high, and target interventions which may be merely educational at the low end to regular calls with members to make sure that they're getting appropriate medications, they're actually taking the medications, and that they're maintaining ongoing care with their physicians. Care management tends to involve more focus on coordination of care among multiple providers, making sure that people are, again, going into their regular appointments, that there's continuity of care as patients move from one level of care, say inpatient, to another outpatient. And care coordination, the other aspect, is really focused. One of the major things that we're looking at will be discharge planning, and that we do expect that the CMOs conduct discharge planning for all patients in hospital care, that they're making sure that those patients have discharge appointments, that they have the proper services in place so they can go home. And for a lot of the high-risk patients, what they're doing is making follow-up calls with these members, making sure that they understand their discharge instructions. If there's need for DME equipment, that's in place and the member knows how to use that equipment. Some of the ways that we'll monitor their case management, disease management programs will be through on-site reviews, and eventually, once we have about a year's worth of history, beginning to look at their annual reviews and evaluations of these programs. I have some stuff up here on emergency room utilization, which I'm just going to skip through because I think Ms. Strigger's already covered those. And let's skip that. I'm just going to talk a little bit just with some specific examples of the disease management programs, and I think the CMOs will get into some more details on this tomorrow. But one example, in terms of asthma, all 3 CMOs do have disease management programs for asthma. The goals are really to enhance member knowledge of their condition. What do they need to do to manage that condition appropriately? They're trying to increase the utilization of preventive services, make sure that people are going to appointments on a regular basis, and with the ultimate goal of decreasing emergency room visits and hospital admissions that are not necessary and may occur if the asthma is not appropriately controlled. Some of the ways that they'll do this will be telephonic contact with members to assess the severity of their conditions, mailing newsletters, educational material to members. All CMOs provide access to 24-hour on-call nurse services. If something comes up after hours and a member has questions about what should they do. Sometimes this can help avert an unnecessary emergency room visit if the member is able to get instructions from a nurse about how they can manage that condition at the time and follow up with their doctor the next day. They'll also make sure that members have and are using medications, and with case of asthma, making sure that they have things such as peak flow meters, and they know how to use those and are using those regularly to monitor their condition. Finally, I'm going to talk a little bit about the quality improvement programs and our requirements of the CMOs for quality. We do require that all 3 CMOs have a quality assessment performance improvement program. And the purpose of these programs is to monitor, analyze, and improve the delivery of the services they're providing to members. CMOs must have an oversight committee, and they also have to get input from providers and members into their quality programs. Some of the ways that we're monitoring these programs are periodically attending the quality meetings at the CMOs, receiving regular reports from them on the activities of those programs, and also reviewing their annual evaluations of these programs. We have required, as mentioned, that the CMOs attain accreditation by either the National Committee for Quality Assurance or Utilization Review Accreditation Committee, and all 3 are going for NCQA accreditation. We have required that each CMO conduct annual performance improvement projects, and they have to do 5 in the area of clinical care and 3 in the area of non-clinical services. Within the area of clinical care, they're required to do performance improvement projects related to health check screens, so increasing percentage of members that receive health check screens, immunizations, blood lead screens, and the detection of chronic kidney disease. They also must do 1 other performance improvement project, and they can select from at least 1 from coordination of care, chronic care management, high volume or high risk conditions. Now, one of the things that we recently did is we asked all of the CMOs to do a performance improvement project on emergency room utilization. And we've told them that could be one of their optional activities, or they could add it as a 6th activity. I think 2 are doing it as an optional, and 1 has made it a 6th activity. In the area of non-clinical performance improvement projects, they must conduct a project in the area of improving member satisfaction, provider satisfaction, and then they can choose a 3rd in the area of cultural competence, appeals, access, capacity, or appointment availability. And last, I'm just going to talk a little bit more about measurement and data and what we plan to be looking at. As I said, we're going to utilize data that's provided to us by the CMOs, as well as looking at encounter data, which we're receiving from the CMOs. We're going to use that to monitor ongoing clinical care and service. Wherever possible, we're trying to use standardized measures because we want to be able to compare our data to other benchmarks, either national or regional. So some of the measures we're looking at are either HEDIS measures. We're looking at some standard federal reports, such as apply to health check screens, and also public health data, such as infant mortality, low birth weight, that sort of thing. On the utilization side, some of what we're looking at, and we will use some of these as proxies for the clinical care provided, things like emergency room admissions per 1,000. Again, where it's high, one assumes that there's not adequate access or people are not using ongoing preventive care enough. Emergency room admissions for asthma patients, overall hospital admissions, mental health admissions per 1,000. We'll look at readmissions and also NICU rates, admissions to neonatal intensive care units. For preventive health indicators, we're looking at things such as health check and well child visits, well care visits for both children and adolescents, access to preventive and ambulatory care for adults, childhood immunization status, blood lead screening, and timeliness of pre- and postnatal care. And then in terms of the provision of clinical care, we'll be looking at things again like the appropriate use and receipt of medications by asthma patients, appropriate screening for diabetic patients. We'll also be looking at follow-up after hospitalization for mental health patients. There's several others. I didn't include them all on this list. And then the final point I wanted to make is that we're currently in the process of procuring an external quality review organization. This is required by CMS for all managed Medicaid programs, and the purpose is to essentially conduct an independent evaluation of the managed care program. So this external review organization will be looking at and validating the performance improvement projects, the performance measures that each of the CMOs is conducting. They'll be looking at that in relation to the overall managed care goals, and they'll be presenting an overall evaluation of how we're doing. So at this point, we'll take any questions that you have.
Thank you. And I would ask any of the department would like to come up, and we're going to begin some questions. First of all, first question, I'm going to recognize Chairman Mickey Chanel for his questions.
Thank you, Mr. Chairman. Mr. Riggers, as it relates to contractual geo-access requirements, can you explain a little bit in further detail about exactly what is geo-access for purposes of the contract, and how does that work?
Certainly, I'd be glad to do that. And it's unfortunate, it's a term we use and what we do, and we toss it out, and we think people understand what we're talking about. So I apologize for probably overutilizing that term. There are contractual requirements for the geographic accessibility and availability of certain provider types. In other words, in my contracts with these three CMOs, I've listed certain providers and have spelled out for them, for example, primary care providers. Every member needs to have, and every member in their networks needs to have the availability of 2 primary care providers within an 8-mile radius of that member's home in an urban area, and 2 within a 15-mile radius of their home in a rural area. For specialists, every member needs to have the availability of at least 1 specialist within 30 minutes or 30 miles of their home in an urban area, 45 minutes or 45 miles in a rural area. It kind of, and we go on. We have hospital availability, mental health providers, dental providers, pharmacy providers, where we're laying out some basic ground rules about our expectations of availability. How you measure that is by using a tool. It's a software tool called GeoAccess. There's more than one tool now, but this GeoAccess was the original tool, so everybody uses that term, kind of like years ago everybody used the term Xerox for a copier. But GeoAccess is a software that it maps the proximity of 2 populations to one another, and it uses latitude and longitude, and you can set your proximity requirements however you want it. So you would take your member population and load it into your software, and of course you're going to have your member address, county, zip code in that. Then you load your provider network in, again by location, and the software co-locates those and gives you a report. I mean, if you set your parameters, again, going back to 2 primary care providers within an 8-mile radius of a member's home in an urban area, that you set those parameters for that. And it's going to, once it's run through the program, it's going to give you a measure of how many members meet that. And so out of, you may have 300,000 members, how many members have that geographic accessibility available to them? And that's part of how we measure whether networks have adequate access or not. And the plans are required to submit those to us on a regular basis for all different provider types. And so we assess those where we feel like is not desired access. We require corrective action plans. The plans tell us what are you doing in that area to try to get that access up. So those geo-access reports, we use it. It's a tool that we use to monitor their compliance with that requirement. If we know that they've lost a provider, I mean, one of the things that we want to see is, it's a geo-access report is a snapshot in time. Networks are generally fluid. I can get a report one day, and if that day there's a provider that's dropped out or been terminated from the network, it can change it. So that's why we get ongoing submissions of those. I can also request them, and anytime I might become concerned about it, I'll want a geo-access report. The other thing that goes along with that, though, that's not the full picture, the other part of that is, are those providers in that network taking patients, and can patients get in to see those providers? So that's something that we require the plans to monitor of their providers, but in addition, we come behind and do our own secret shopping, so to speak, where we're calling providers ourselves, acting like Medicaid members, trying to get appointments with providers to see if truly they can get in to be seen.
Follow up, Mr. Chairman, right. So basically kind of a map with pins in it type thing, is that?
Yes, sir. That is one of the byproducts of it. You will get a map that shows that as well.
Well, let me ask you this. In addition to the map with pins in it, how about outcomes, and I'm talking about contractually. Let's say you have providers that meet the geo-access requirements, and you mentioned that you asked the CMOs to monitor if they actually doing it. But I mean, is there any contractual requirements that says that there is a bar that they have to meet in terms of percentage of patients who are eligible who actually go see a primary care provider or a dentist or something like that? I mean, other than the pins in the map, how about outcomes? I mean, for example, let me give you an example in my district. One of the counties that I represent doesn't have a single dentist that takes Medicaid nor Peach Care. Help a Child Smile happens to go to that county. And, of course, that's the subject of ongoing discussion among the CMOs and various providers as to the eventual outcome of that. But how would you, just to pick that county, but I'm sure there are many, many more, that is currently getting service, and whatever the percentage of them is, and certainly you all should know what percentage of the kids are getting service, then all of a sudden that goes away in that county, and there's not a single provider. How can you explain to me how then that would be adequate access if those kids have to travel by definition at least to the one county over and maybe further than that? Outcomes is what I keep hearing geo-access, but I don't hear, and I'm not sure that you're saying that there are contractual requirements for them to do something as providers other than to sign up. I mean, what about that? How do you measure that, and is that contractually required?
It's a good question, and probably Dave's going to have to help me answer that. There are two pieces of that, and I think each of us addressed your concern about not only are the providers there, but are members getting in to see those. And that's a valid question to ask, and something that we look at in both ways. The plans, my contractual requirement of them is that they have a network of providers that meets certain minimum requirements. And in this particular situation, Help a Child Smile, because they are vans and there's not an address, typically they're not even listed in the geo-access requirements because there's no way to really map them because there's not an address to map them to. So the geo-access requirements that are met with the providers that are there and have addresses. Your issue about are these kids actually getting in, or anybody is actually getting in to be seen, will be addressed by us when we look at the healthcare outcomes. At the end of Dave's presentation, there were several slides with outcomes that we're looking at, 20 plus outcomes, and we're going to be adding. There's a couple of those. We're still in the process of modifying a couple of those. We're probably going to add a vision outcome and probably a dental outcome is on there, where we're actually, that will tell us are members getting in and getting dental care, and we've already benchmarked it against. We know what we are right now in fee-for-service. Before we went into managed care, we already have that benchmark data, and that's what we'll be measuring the plans against. Is are you able to bring that up above what we had in the fee-for-service environment?
Final question, Mr. Chairman. In other words, you'll know that outcomes 4 or 5 months from now. I think you said sometime next year y'all have that. But again, the heart of my question is there requirements that providers see a certain percentage of people, and do you measure that
Well, I don't think there's...
Versus just having a pen and a map.
One of the frustrating parts of that is that we have a contract. We talked about contractual accountability, which we think is important. That's the way business is done, based on a contract that outlines expectations of the two parties entering into the contract. I have a contract with the CMOs. They have contracts with providers. One of the things that has been frustrating for all of us, meaning DCH, the CMOs, and the providers, is that in the fee-for-service world, we never required providers to notify us if they were not accepting new Medicaid patients. So in the fee-for-service world, in traditional Medicaid, we never had a clear picture of really what access there was out there, because a provider can, at the point of service, decide whether he may take this provider's Medicaid, this member's Medicaid, but not this member's, or close to new Medicaid. That is, we've allowed that to happen. Under the arrangement or the business relationship between the CMOs and the providers, there is a requirement for there's a contractual notification requirement that providers notify their CMOs if they have closed their panels to new patients. I think that that's new for providers. They certainly, as I said, we've never required it of them before, and so we have situations now, we're finding out about situations where a provider may have said, that's it, I'm closing, I'm not taking any more new Medicaid patients. And the reality was they needed to notify their plan about that. Plan didn't know about it. It's a continual education process. I do not believe that there are any contractual requirements that between the CMOs and their providers that they see members a certain number of times. There is a requirement that they provide all medically necessary care to that member who comes in seeking their services. It's not a perfect answer for you, Representative Chanel. I understand what your concerns are about that, but having the contract requirements in place, monitoring the outcomes, and having expectations on outcomes is how we will see the improvement over time.
Thank you. I've got a couple of questions. First of all, is true or false, the CMOs self-report their member network?
Their what network?
Their network, the members in the network. They self-report that, correct? The
provider networks? Mm-hmm. Yes, but we also verify that by a number of different things. Again, calling and verifying. We also require submission of signed contract pages. So while they report that to us, we also come behind to verify that in many respects.
Okay, thank you. And I have a hard time understanding, excuse me, of understanding the network in that. How can you come up with a network when you're not sure? Is there a benchmark on, for instance, let's talk about the dentist. Not every dentist that is a Medicaid provider sees everyone that walks into their office. They may limit it to 3 a month. So we're talking about a pin on a map. But is there a standard that you go by? And if there is, how did you arrive at that standard? You may say in my hometown there's 5 providers, but I may know that they may no longer really accept new patients, Medicaid, but take the ones there. How do you come up with the access there?
Well, that is part of the change. I mean, this is a big change. Again, that the contractual terms between the CMOs and their providers, those contracts state that those providers will not turn people away, that if they make a decision to limit them, that they have to notify the plan in advance so that there is knowledge that maybe there's not enough access there. The point about, so again, that's a learning curve. That's very different from the way it was. It's a learning curve that there's a contractual requirement to accept members. If you're going to close your practice, you need to notify them so they're aware of that. We also are monitoring that by calling providers to ask, are you currently accepting new Medicaid patients? If so, what is your appointment availability? How long will it take a member to get in? We're coming behind that and monitoring that as well. The plans do all of that. We take those reports, but then we do the same secret shopping as well.
And have a list of all those that you called?
Mm-hmm.
And how often do you call them?
Probably there's some calling going on a regular basis every week. But I would not say every provider gets called every week, but provider calling is part of our routine monitoring activities.
Okay, let me ask you.
We have stepped up, obviously, Senator Goggins, we have stepped up the monitoring with dental access tremendously.
Let me ask you a question in that we're discussing adequate access. Why would we even, and let me make this comment, the CMOs as well as your department, every time I call, are very helpful. It seems like I get calls every day on getting claims paid or getting someone in the network. But if we're talking about a problem with access, why would we even limit the number of dentists? We have an X number of children on Medicaid that need to be seen, correct?
Yes.
Why does it matter how many you have out there? Those kids need to be seen. So why would we close our panel to these so many dentists? Why? I don't understand that concept. Why not have as many dentists out there available, or doctors or so forth, because you only have so many kids and so forth to be seen?
And I think probably you might want to ask this question of each one of the plans, and I'm sure that you will when they present tomorrow. One of the tools of managed care is, there are many things that managed care can do to help control utilization and therefore help manage costs. One of the things that is a managed care tool is to limit provider networks. And I'm going to talk outside of Medicaid managed care and just talk about managed care in general. Typically, if you are in an HMO, which CMOs are HMOs, that you might have a smaller network of providers to choose from. Still going to be an adequate network, but a smaller network, because one of the tools of managed care has been to negotiate price for volume. In other words, to steer more patients to certain providers who will take less price-wise. That's a managed care tool. It's been around for years. And there's kind of a pendulum that swings between cost and choice. That in the early 80s, very restricted HMO networks were typically the norm. People didn't like having choice restricted. That pendulum started to swing back in favoring choice. And so HMOs tended to broaden their networks. Prices started rising. It's a continual swing. Again, with Medicaid managed care, a little bit different animal than a commercial managed care plan. Typically, you wouldn't want to restrict your network as much as a commercial HMO might. You've got access issues. You've got members who can't travel as much. Years ago, if you were in Kaiser Health Plan in Atlanta and you wanted to have a baby, you went to Northside Hospital. That was it. It didn't make any difference where you lived in Metro Atlanta. You were traveling to Northside Hospital. Again, that has changed somewhat, but conventional wisdom with Medicaid members, you need to have more providers available. Mm-hmm. However, in the current situation, I think all three of the plans made an assessment that dental was something that they needed to pay some attention to.
Well, let me ask you a question on that. We keep hearing that we underfunded, the legislature underfunded dental in the budget. We hear that all the CMOs are losing money on the dental. Do you feel like we underfunded them?
You haven't heard me say that the legislature
I'm just asking. No, I'm just from a budget standpoint. Did we underfund them?
I think that all three plans experienced much higher dental utilization than they would have expected based on the data that they initially bid rates on, which, if you will remember, was older data. And there is always a risk when you are using older data and trending it forward that you can make some errors in that. Mm-hmm. And as I said, they've all experienced much higher dental utilization than they anticipated, and are doing what they feel like is necessary to provide the medically necessary care within their budgets.
But that's good that we're seeing more kids and taking care of them.
I think that there is dental utilization that we want to see and some that we do not.
All right. Thank you. Well, let me ask you another question. CMS's target for the Medicaid population is about 55%.
You're talking about dental penetration?
Right. And we're at 36% right now. So can you respond to that?
I think that will be obviously an area for performance improvement and increasing the type of utilization that we want to see in Medicaid children, which is obviously their routine cleanings per year, their exams, sealants, fluoride applications, the things that we think that will prevent more extensive dental work later on. And certainly we want to increase that.
Also, we talked about the 1-year baseline. We've been the 1 year, and it takes about 3 to 5 years to really get an idea of how this is working. Why are we allowing, or why have so many contractual changes been proposed when we realize it's 3 to 5 years out, that this is where, we want to start tweaking it then?
By contractual changes, you mean the things that have happened within the dental provider community?
And others.
I don't disagree that communication could have been handled in a better manner. I think we may have had some conversation about that. Certainly, it has been confusing for dental providers to understand the changes, and certainly that could have been handled better, more smoothly. But also, it's something that needs to be addressed now.
They had the 98% clean claims, and I understand the clean claims prospect. What is the percentage, can this be provided, percentage of initial claims that are reported that are denied?
I'll have to get back to you. I can't. John, do you by any chance know that right off the top of your head? No?
I mean, I understand a clean claim is easy to pay them, but it's the time period between there. And what is the percentage of initial claims get denied, and then what is the time frame between the initial
filing and the resubmission?
That versus until it's considered a clean claim. Is there any way you can do that for me?
I will work on that for you.
Okay. Let me one more, and I'll quit hogging this. This has got to do with, and someone asked this to be put in the record, but I'm going to cut it really short. Someone had worked with DHR, and the comment is, in every state that has managed care, the early intervention population is either carved out or enrolled voluntarily. Georgia is the only state in which young children with disabilities are required to be in Medicaid managed care. In my current role, I work with adults who have not had the benefit of early intervention programs. It is costing the state and Medicaid significant dollars to serve these individuals. Early intervention saves money by reducing the need and intensity of long-term supports. It makes no sense from a public policy perspective not to mention humanitarian to deny needs services to children with disabilities and their families. I have no idea. Is that correct, that we're the only state that does that, or is that incorrect statement?
I'm sorry, I can't address it. Dave, do you know that?
I don't know if we're the only state that does that. We probably have to look.
If you would, thank you.
We can look that up.
I appreciate your indulgence.
The plans are required to provide those early intervention services. The manner in which they provide those is up to them, however.
And I appreciate your indulgence there. I'd like to recognize Representative Amers.
Thank you, Mr. Chairman. Over the past year or so, I've been reading many research articles that indicate health information exchange could decrease the cost of doing business. We here would like to get the best medical care possible for our children, and yet we don't want to break the bank. Are you requiring, or the CMOs requiring, that the primary care providers reduce their medical records to electronic data so that this data can be exchanged and so that the local hospitals can access that data when someone shows up at the ER?
That is not a requirement at the current time.
It would be one way to cut out a lot of money.
I think that tomorrow, when the 3 CMOs are here to give their presentations, I hope you'll be back for that, because I certainly think that that is something that you could address to each of them.
Thank you very much.
But it's not a requirement of us for them at this point.
Representative Stevens.
Thank you, Mr. Chairman. I guess this is the extent of our legislative oversight. We might want to consider even having some more, since there's a lot of interest in these this first year of growing pains, so to speak. But my question comes to probably something that it's unforgivable in my mind, and it has to do with eligibility files with the CMOs not being in sync with the state files and eligibility. I've had some reports where a person might have, which happens a lot, by the way, fallen off Peach Care or Medicaid, and the information may not have gotten to the CMO on a timely fashion. Could be 2-3 weeks. The particular provider then goes ahead and sees the patient. The provider is paid and retroactively is recouped by the CMO because their provider files are not up to date. I would strongly suggest that that's unacceptable to me, that within our contract that we have the CMO and the state eligibility files in sync.
Well, this may or may not make you feel any better, Representative Stevens, but we do sync those files with the plans. They get a file from us. The way the eligibility and enrollment in the plans works is that members are determined eligible for Medicaid. They go into the ACS system from Success, which is the DHR system. This may be more than you want to know, but it's probably good information for you. They come in, the system looks at the category of eligibility to see if this is somebody who is eligible for Georgia Families. A file is immediately sent out to Maximus, who is our enrollment vendor. You see them as Georgia Families. They do the outreach to the member to say, we have a program for you and you can choose your health plan. That member has a period of time, a 30-day period of time to make their choice. That's federally required. We run a program once a month on the 24th of every month that puts members who've made their choice, or if they haven't, who are auto-assigned, and we send that file to the plan on the 25th of the month. And again, the timing of the member's 30-day choice period plays into that. If by the 24th of the month they haven't had their 30-day choice period, it's going to go to the next month. We run that program on the 24th, send the file to the plan on the 25th. They take that into their systems. They immediately have to begin their outreach activities to their new members. They have ID cards, welcome packets. They got to get that information into their system. So that last week of the month is huge activity for them because they want to get those cards out as quick as possible, because on the beginning of the month they want those members to have those cards and to be loaded into their systems. Then we run another program on the last day of the month. And what that program does is tell us anybody who's lost Medicaid eligibility in the last week of the month. And we ship that file out the door, usually early on the first day of the month, to say, here's anybody who lost Medicaid eligibility. Because we don't want situations where, I've told one of the plans, you've got John Doe. John Doe lost Medicaid eligibility, but the plan thinks that they have him for the next month. Providers verify eligibility, exactly the kind of situations that you've talked about. So those files are synced up, and people don't lose their eligibility. It's always for the next month on that. Where we have had some situations occur is and this is something that we are working to improve, all three of the plans, and working with us on that, and that is not only do they have to get that eligibility information, but they have subcontractors that they have to share that information with as well. So we're pushing it out the door as fast as we can to get it to them. It's got to go to their various subs, their PBMs, their dental subcontractors, their behavioral health subcontractors. That's where we've had some issues with timing there that you are referencing.
And again, I appreciate that, but it shouldn't be on the back of the provider when he in good faith says that he goes to the portal for his CMO, which he's required to do, not the state portal, and they tell him this person's eligible. They get paid, and then through no fault of the provider himself, has that payment recouped because of a timely problem between the state and the portal that the provider is having to use. We ought to contract that.
I understand your issues with that and the concern with that. I would also tell you, though, that in the commercial world, anytime a provider signs a contract with a commercial health plan, there is always going to be a contract, and I know because I used to be on the provider side and I did this kind of contracting for years. They will tell you a verification of eligibility is not a guarantee of payment.
I can tell you now, as a pharmacist, I have never had a claim to come back.
Well, you're in a different situation because you get your eligibility verified at point of sale, but it's a different situation for pharmacists.
I understand. Don't ruffle a feather there.
Representative Stelzer.
Thank you, Mr. Chairman. And Ms. Driggers and Dr. Nair, I appreciate your detailed walkthrough with us. My first question could be to either of you, but it deals with the idea of healthcare consumerism. Most of what we've talked about is the CMO's process of managing care, managing behavior appropriately. And I recognize in any network like this, we're not going to get 100% of our population exercising regularly, eating a high-fiber, low-fat diet, and so forth, as we'd like them to. But how can we use, moving forward, elements of healthcare consumerism that will really influence behavior so that the decisions and that the actions are not only within the CMO and within the health management structure, but also with the consumer themselves, the health consumer? I know there have been some programs in other states, some of them privatized programs, where meaningful incentives have been in place to manage cholesterol, blood pressure levels, obesity, those kinds of things. And there's some metrics that are starting to emerge that can be tied to financial impacts and cost savings. Do we have a specific plan in place, or could you give us a commitment that moving forward we can look at ways to use those elements of consumerism to not just have the CMOs make the decisions, but also have the consumers themselves involved in a meaningful way?
I am so 150% with you on that. I would always welcome ideas about that. A couple of comments I'll make about that at the current state. The plans do use some incentives now to encourage healthier behavior. Some of the plans use things like offering strollers, inexpensive little strollers to women who complete their prenatal care. Some of there's little incentives, and you'd be surprised. Like a $10 Walmart gift card is a big incentive, but to incentives like that to complete childhood immunizations, all those regularly scheduled ones. They are doing things like that. One of the things that we could do on the state side, one of the things that's a challenge for us with the Medicaid population is that we can, in commercial plans, we can use financial disincentives. Right now, if I go to the emergency room, it's going to cost me $100. So it does make me think about whether I really need an emergency room or whether I can wait till the next morning and call my doctor. Right now, I think $3 is a Medicaid recipient's copayment for using the emergency room. And a provider, by order of CMS, can't turn away a member for their inability to pay a copayment. So it puts providers in a real bind. One of the things that we could do is to perhaps think about redoing Medicaid managed care under an 1115 waiver. We did Georgia Families, the federal authority that we operate under is a state plan amendment. And with, there's pros and cons both ways, whether you go state plan amendment or waiver. State plan amendment means we can't do some of these neat bells and whistles like you were just talking about. If we wanted to continue that and think about things like that, we might want to consider using the 1115 waiver as a vehicle to put some things like that, some incentives, disincentives for members. When we designed this program, we wanted to have a nominal copayment for a Medicaid member based on had many discussions with the hospital community. We felt like at least a $25 copayment might begin to help change some of that inappropriate use of the emergency room. We did request that of CMS, and they did deny us that ability to do that under a state plan amendment. So there are ways that we could, and I'm with you on that, and I'd welcome ideas for that as well.
And really the heart of my question is that recognizing there are limited resources.
Yes.
Every member, every consumer in the system that has a body mass index of over 40% body fat, and they have cholesterol over 300, and their age 32, they're setting a pattern to be very costly and frankly taking resources from others. And I think to the extent we can incentivize and find ways that, and I know there might be some moral objections from some sectors on that, but I think that's the best thing overall for folks is to help themselves. And Mr. Chairman, can I ask?
Yes, please.
I would just encourage you to, as we move forward, I sense some interest from my peers in the General Assembly for that kind of approach, and I would like to explore that over the next few years if we could. Okay. I do have one other question, then I'll conclude, Mr. Chairman. I'm also sensitive with the growing pains of integrating all the players involved in this managed care system, that over time for this to work, the system itself has to be a win-win-win. A win for the state, a win for the CMOs, and a win for the patients. That all three of those over time have to be winners in this. It has to be sustainable. And I'm certainly sensitive to the quality issues that you look at. How has this first year been, first several months been financially for the CMOs? I noticed that there's a quarterly and annual financial statement requirement for you to look at their financials. I ask that from a bottom line standpoint and also from a contractual terms and conditions standpoint, that very often as programs start off, all the eyes are on the provider for providing the service, but frequently it's very difficult for them to do that, and it's not an easy road to hoe for them. But ultimately, if the CMOs are not successful financially in this whole system is going to fall apart.
Absolutely.
First part of my question is, has it been successful for them financially? And secondly, how can we make it more successful for them either financially or contractually so they can do their job better?
I hope you ask them this tomorrow as well. I think that for this first year, when you have a startup business, then there's a certain expectation that you're going to have costs in the first year that you might not have after a period of time. So again, these are three veterans. They've certainly managed Medicaid at risk in other states. They do pro formas. They understand that, again, using the analogy of talking about turning a battleship, it takes some time to do that, that they were probably not going to be wildly profitable, and they're not ever wildly profitable anyway, but that the first year was going to be tough. I think they've all experienced, it's been a challenge. Again, there are many factors going into that. Georgia's a huge state. Healthcare is local. Every healthcare community is unique. We have large rural areas. There are challenges with that. We've got years of utilization patterns that need to be changed, and I think that I don't think any of them would tell you that this past year has been a great year financially, but they're here for the long haul. They're committed, and they're working as hard as they can to turn that battleship.
Representative Smith.
Thank you, Mr. Chairman. One comment and then, or two comments, and then I'd also like you to address those if you could. And I know that when these contracts were being developed, they were developed based on some pretty old data, 02 data or something like that, if I'm...
The rates were, right?
Yes. And it's hard to develop a contract when you've got old data. However, I have received some information or some comments from some dentists, and we've talked about dentists a good bit this morning, that since January the 1st, there have been a minimum of 14 contractual changes. And also, there have been somewhere between 50 and 100 dentists that have been taken off the provider list of two of the CMOs, and which could equate to thousands of kids when you start talking about upwards of 100. Could you comment on those two items, please?
There have been changes, no doubt about it. I mentioned that a little bit earlier in response to Senator Goggins' questions. Certainly acknowledge that the dental community probably feels like it's caught in a revolving door. Acknowledge that probably some of that communication could have been handled much better. As I said, all three plans have experienced much higher dental utilization and cost than anticipated. Looking at ways to try to control that, still have good dental networks, still have access to care for kids. There were some discussions that began with one of the plans about putting some prior authorization limits around certain services, which they are entitled to do. They worked with us to make sure that was still within the scope of Medicaid services. There was some discussion about reducing some fees on a limited set of the fees. One of the other plans decided to do a similar thing, and then the third plan also decided to not adopt exactly the same changes, but some similar. So there was communication about that, which was, again, many dentists found that distressing. Then a plan decided to look at a rather innovative way of reimbursement to help control cost, which was not received well by dental providers at all. And many providers were saying that if that went into effect, they would not be part of the network. There was great concern by the department as well as that particular CMO, that we were watching that very closely. That CMO did decide that that was something that we were not going to address at this time, and went a different direction with what they needed to do. But in the meantime, there were providers who were objecting to the fee schedule changes and were saying, if this goes into effect, I don't want to be part of the network. Honestly, there was confusing information that was going back to them. That's part of I think the dental community in Georgia is probably really tired of being contacted by either one of the CMOs or one of my staff at this moment. They probably look at the caller ID when that phone rings and say, I'm not answering that phone. But again, we're trying to clarify for them what is happening, make sure that we know which dentists are still participating. We are monitoring the dentists because, if a dentist decides, I don't want to do this, I'm out of here, then that is a business decision that a dentist can make. I mean, they certainly have the right to make a business decision, and if they feel like the reimbursement changes are not going to work for them, they have the right to get out of the networks. We are monitoring that. I will get geo-access reports this week as well as next week to take a look at what any provider terminations have done to the access in that particular provider's network. So that's what we're doing on that.
Why would CMOs remove somewhere between 50 and 100 dentists from their plan?
They were not removing them. Again, the dentists were exercising in their contract. They have the ability to object to any reimbursement changes that are occurring, and then there should be some dialogue between, and you understand that all three of the plans use dental subcontractors to provide those services.
But I understand that they were, the term that I heard was terminated from their contract.
Well, again, what happens at the result of an unsuccessful discussion about the rate reductions is that the provider is no longer participating.
Thank you. Representative Gardner.
Thank you, Mr. Chairman. I have several questions that fall under the heading of the goals that you described on page 7 at the very beginning. Number 2, you talk about the contractual accountability, and in the win-win-win situation that Representative Sessler designed for us, everybody would save money or make money. And my concern continues to be what are the costs of monitoring the CMOs? I mean, we know that this accountability is important. We know that we need to make sure that the services are being effectively provided. But when I hear you talk about the different ways that you're monitoring the CMOs and doing your secret shopping and doing the monitoring of the providers, I get concerned that if we add up the costs of monitoring and what we're paying the CMOs, I mean, I guess my question is there a point now at the end of the first year where you could actually show us what it is that your department is spending on auditing and monitoring and secret shopping? And you may not have that information now, but I'd really appreciate knowing the costs to the state of making sure that these CMOs are doing their job. So that was really my first question.
I guess we could probably do that. I have a staff, there's 25 of us in my division, and my 25 folks are doing this monitoring and oversight, and they work hard.
I know they work
and
hard.
And they, I guess you would, we could calculate what we make. Of course, remember, we work for the state. And then what we are anticipating paying as far as audits go. If you want us to do, we can.
I'd like a figure that shows that cost compared to perhaps what you were doing before the CMOs. And in terms of the outcomes that you described, you indicated that it would be 3 to 5 years before you could really show success. But at the end of the first year, I guess you suggested in January of 2008 you would finally have some information about the first year. Will you be able to show us the reduction in the emergency room utilization?
We should be able to show you what the emergency room utilization is. I won't promise it's been reduced, but yes, we should be able to show you this is what utilization was before managed care, and this is what it's been in the first year.
We're going to do annual report cards, and we will start with the first year, even though we don't expect huge change in the first year. But that's been our plan all along, is to do annual report cards.
And just to clarify, it'll probably be closer to the end of the first quarter, beginning of second quarter that we'll have all the
So you're saying after we go home in April?
Maybe right before you go home.
We'll make that our goal.
Yeah, we'll work to get it to you.
Not April, January.
I'm not so sure on January, but first.
Well, we hope that you will make that a priority in any case. May I ask one more question, Mr. Chairman? At the bottom of this page, you talk about one of the goals is budget predictability, which apparently has been achieved, unless you count all the additional costs of monitoring, which was my first question. But then you talk about simplicity, and you said simplicity for the department. Do you think that we have achieved simplicity for consumers and providers with this new system?
Well, the answer that I give you might be somewhat different from an answer that you would get, and you probably will later today, from some of the providers that are here. Certainly the goal is not to make this more of a challenge, but yes, when you have 3 different companies and they do get to do things 3 different ways, there is, as I said and acknowledged in the beginning, this has been a big change. I wouldn't minimize that.
I thought you clearly said it was simplicity for the department, and I wanted to, I guess, point out that it hasn't been simple for consumers or for providers. One last question, Mr. Chairman, and that is about the requirement from the federal government that 95% of the eligible people in Georgia who are eligible to be in Medicaid, how close are we to having the number of eligible people who are eligible for Medicaid to be enrolled in the Medicaid program? I've just read in the paper that that the government is going to require that before we can expand any Medicaid.
You're talking about that for S-CHIP? I thought the requirement was to expand the S-CHIP program. The states had to have 95% of children eligible for S-CHIP actually enrolled.
And how close are we? So this is for S-CHIP and not for Medicaid?
That's my understanding.
Okay. And do you have any idea how close we are to 95%?
I don't know because we don't monitor that enrollment in our department, but we could get that for you.
That would be terrific. Thank you very much, Mr. Chairman.
Senator Regina Thomas.
Chairman, I certainly appreciate the time that you put into this, and I know that you want to do all that you can for those who we provide coverage for. And a follow-up from one of the questions about the providers coming out of the network, how has this affected services, and do we know those who have been covered by those providers, and can we put them in with another provider immediately without affecting the services?
Are you speaking of people who have been with a particular provider who might not be part of the plan's network?
Yes.
In that situation, it is the plan's responsibility to find a provider for that member and get them with care. Again, that goes back to the contractual accountability. I can hold that plan accountable for making sure that there is transition of care. If someone has been under the care of a particular physician, that physician is not part of the network, that is plan responsibility to have a provider available of that particular specialty to get that member in with them.
Okay, thank you.
Now, and one of the things that's a challenge there is to make sure we know about those situations.
And that leads me to my next question. Do we have, and I think someone might have mentioned it, an integrated system software wherein we would know where our members are and when they are not covered by a provider?
Yes, the plans do know that. As I said, back in the beginning, when a member is newly eligible for Medicaid and eligible to go into a plan, we would really like for them to go into their plan with a chosen primary care physician so that on their first day of enrollment in the plan, which is always the first of the month, they're going to be a new member of AmeriGroup Peach State or WellCare with a chosen primary care provider. However, in the circumstances where someone chooses a plan and doesn't choose a PCP or doesn't choose at all, and there are people who don't, they throw the information away, the plan will make sure that they are auto-assigned to a primary care provider under an algorithm that we have dictated to them, and that member gets auto-assigned within the first week of enrollment of that plan.
Mr. Chairman, 2 brief questions, if I will. You mentioned earlier, Ms. Driggers, about a 90-day for the babies. Do we still have that 90-day waiting period before we can insure our baby?
No.
Okay.
No, ma'am. If a baby is born to a CMO-enrolled mom, that baby is covered from the date of birth. There are some circumstances where newborns are eligible for coverage. However, there has to be an application process for them, but the deeming process where babies are covered from the day of birth, if they're born to a Medicaid-covered mom, then they are covered from date of birth.
But if they're not, then that's that application period that takes the 90 days.
They look just like any other new applicant for Medicaid. And I don't know that it necessarily always takes 90 days. There is some time period it might take.
Thank you. One last question, Mr. Chairman, if I will. You mentioned earlier about the refugees that we are providing coverage for. Do you know the number?
It's a handful. I'm talking about this is a very specific. This is not and I always need to be careful to explain this. This is not a situation that we're talking about that concerns people about illegal immigrants being covered. The refugees they're like people that have been granted political asylum. It's a handful of members, maybe a couple of thousand. So it's not. They've been granted political asylum for various reasons, and they're eligible for Medicaid because of that.
Representative Hughley.
Thank you, Mr. Chairman. My question goes back to the question that was asked earlier about the changes to the dental contract. And you all are amazing in that you have these 58 reports that you look at and whatnot. How are you going to be able to accurately assess where we are at the end of the year with dental services when you have allowed so many contractual changes within that small window?
We assess the networks, again, on a regular basis. We look to see if there's change in that. The plans are required to submit those to us. We make the assessment, are they meeting the geographic access requirement? We're calling providers to make sure that they're accepting Medicaid patients and are seeing them within a timely manner.
So you have approved all of those changes and as they have appeared? Is that what you're saying?
Yes. Yes.
And so you're telling us that you don't feel that any of those changes have adversely impacted access and quality of care?
We will continue to monitor that. At the current time, very few of the potential terminations have taken effect. So we will see, we'll be looking at this over the fall and into the winter.
On your geo-access report, can you give us a snapshot in terms of where the gaps are in coverage in our state, since you got the maps and the dots and whatnot? On any particular day, can you tell me, if I ask you about a particular area, where the gaps are in terms of primary care physicians and specialists?
Yes, ma'am.
Can you get us a report like for today? Because it'll be after the fact, so if you choose a day.
You mean as of today?
As of today.
Sure.
Where are the gaps in our system? Where are we doing well? Where we're not doing well? I guess my bottom line is, with all the reports and all the conferences and all the monitoring, I expected to hear more of where the system was, what we're looking like, and what you expect that the report that you're going to come up with next year is going to look like, and I didn't hear that in the conversation. So
you were looking for more specifics about outcomes and
about where we are. We are, because we're almost a year into it, and I know the official reports will come out with the data that will back it up and that kind of thing, but with the kind of monitoring that you do, the kind of reports that you have, and the kind of interface that you have with the contractors, I would have expected something more in terms of where you feel this system is.
Well, for example, the question that you asked about, you were asking about certain access levels. For all three plans in the Atlanta region, Jasper County is a challenge because there are, again, you end up with a couple of situations when they're trying to meet geo-access standards. First of all, are the physicians there? Are there even physicians there? You heard Representative Chanel talk about the fact that in his particular area there's a county that doesn't even have a dentist. That we have that situation in other parts of the state. Jasper County is a problem for all three plans. Haralson County is a problem. Outside of, in other parts of the state, Harris, Heard counties are challenges. I know where there are issues where the access is not as much as we would like to see. Part of the discernment that I have to do is to discern and work with the plans. Is it an issue of the fact there are not even any providers there? Are there providers there who just don't really want to be in the plans? In that case, I'm going to lean on the plans and say, you know what? You got a provider there, you really need them in your network, and if you don't have somebody in proximity who can take those members, I don't really care what you have to pay them, but you really need to get them in your network. And we've had conversations like that. They understand that their obligation to me is to provide me a network of providers for my members. So, yes, I am aware of the parts of the state where there are challenges for various provider types This is part of the ongoing communication that I have with the plans. Okay, what are you doing down there? You know, what's your plan for access? You don't have a provider in that area. Where are people going for care? So that is something that we keep a very close watch on.
Well, as members of the General Assembly who represent those areas, it would be helpful for us to know where the access concerns are, as you put it, and what is being done to address those concerns, so that when our constituency calls us, then we'll be in a better position to address their concerns.
Okay.
Thank you, Mr. Chairman.
Thank you, Mr. Chairman. I guess the question that I'm asking is somewhat redundant, but I think we're all concerned about, as we enter the end of the first, I guess, performance year with the CMOs, what are we actually saving money? This is what it was sold to us on, that the state's going to save X number of dollars. Now, I know that I think in one of these goals it said we were going to do it through effective utilization management. But I guess my question is this. What was the anticipated end of first year savings for the CMOs? And do you have any idea, are we going to save any money at the end of the first performance year?
$248 million in total funds.
Was the savings that we were actually told?
Yes, sir.
Now,
I knew you would want to be. I knew you guys would be interested in that, so I was on the phone.
$248 million
Total funds.
Now, we're only about a few months out of the end of the first performance year, and I know you can't give me the exact. Are we going to be anywhere near that amount?
Yes, sir, because of the way that the savings are calculated for us. Remember that we pay a monthly premium to the CMOs, right, much as you pay a car insurance premium. So you know what your outlay is month over month for the risk that the car insurance company is taking to fix your car. We're doing the same thing. We pay a monthly premium, so we know what our outlay is going to be because we know what our membership is. Yes, there are some fluctuations. So that's where we get the budget predictability. So we know what our costs are going to be for that year and what we're going to be paying out. Those savings were taken off the front for us. So we know that the state has achieved the savings.
And was this as a result of utilization management, would you say, or not?
Well, the way that premiums are developed for a CMO, they are based on past experience so that they're not just plucked out of the air. There's a requirement by CMS that any rate that is paid or premium that is paid to a managed care company be actuarially sound. So the rate has to be based on actual expenditure. There's certain trends that are associated with managed care savings. For example, we do expect them to be able to decrease preventable hospitalizations, increase physician office visits. But again, our saving, and that's how a rate is developed, that we pay to them, but that, again, our savings are taken we see our savings on the front end.
Right. And the only reason I'm asking where that savings is coming from is I don't know if a lot of you may have seen the report on Good Morning America about an individual that was denied coverage, and that later after the report the person was able to get coverage. I guess my only concern there is if we are saving, that we have safeguards in place to make sure that people are getting the services that they need and that they're not being denied. And I guess that's my next follow-up question is, do we have in place, as we go into this new era with utilization management, some form of safeguard for those individuals to make sure that they're not being denied coverage or they're not getting the services that they should receive?
It's absolutely a valid question, Representative Hurd. Absolutely. Yes, we do. We do a number of different things. We audit the plans ourselves. As we mentioned to you, we have audited all 3 of them on the timeliness of their prior authorizations because that has been a concern. There are contractual requirements for that timeliness, and that's to make sure that people do get care that they need in a timely manner. We also will be bringing on an external quality review organization. That is something that's also federally required, an external vendor who will monitor the quality and provision of care. And then members also, besides our oversight of that, then members also always have appeal rights as well.
Thank you.
Just one follow-up to Representative Hurt. The $248 million, that's total funds.
Yes.
That's not. What is it in state funds that we've saved?
You'd be better to ask Carrie that. It was about 60-40 split on that.
$78 million. Representative, hold on for those who are hungry. We have one more. Recognize Representative Henson.
Thank you very much. And I think I've got 2 or 3 questions, but my first one goes back to children enrolling. You had brought up the 95% issue. I talked to my DFACS office recently because a constituent had tried to enroll her child in Medicaid, and they said she was over the financial household limit for that. And I said, well, doesn't she automatically get enrolled in Peach Care? And they said no. They're dealing with HIPAA rules. They can't send it on and all. When we put the SCHIP program into place as Peach Care for Kids here in Georgia, I was always under the impression that they applied through the DFACS office. DFACS determined eligibility, income eligibility, and put them into the right program. And yet it sounds like now they're telling the parent, oh, you have to call this 1-800 number and start a whole process over again. Could you comment on that? Because I have some grave concerns about mothers trying to enroll their children.
There are separate enrollment processes for Medicaid and Peach Care. There is not a passing on of the information. However, there have been situations in the past where parents might have applied for Peach Care and they were not eligible for Peach Care but were deemed eligible for Medicaid and so enrolled as a Peach Care Plus member, which really in reality was Medicaid. But there are 2 enrollment tracks. The enrollment process for Peach Care is, my understanding, it's a very easy process. It can be done, I think, over the telephone, via the web. I'm less familiar with that enrollment process, so don't write down what I said as carved in stone. But it is an easy one. It is not a complicated process for enrollment in Peach Care, but there is no moving back and forth of applications. There are 2 different funding streams, and so there's not one application doesn't serve both.
Okay. Another question that I had was with regard to the 3 CMOs, patients that can switch at the end of a year contract or within the first 30 days, but yet I've also heard there's no communication whatsoever between or transfer of information on a patient between the different CMOs. Is that correct?
No, let me make sure I understand the question. You are asking about the members' ability to change plans. They can change plans within the first 90 days of enrollment for whatever reason. If they do not change plans, then they're in that plan until the end of their first year. They do have an ability to change their plan on an annual basis, much as we do. We can during our open enrollment period, but that open enrollment period is specific to each member depending on when they came on Medicaid.
My concern with that is more of the medical, dental, or whatnot records being able to follow the child. And I heard the CMO's computers do not talk to each other.
They do not pass information back and forth, no. However, all 3 plans have agreed on transition of care guidelines so that they work together to try to transition it, but there's not an automatic passing of claims information from one CMO to the other.
And I guess lastly, I have a grave concern with the dental and what is happening, not just for the larger groups that are here in the state of Georgia, of which we do seem to have some termination without cause just because of reconfiguration, I think is the word that's been put out there. but also with the individual dentist who is unable to enroll because they're no longer taking dentists, or the CMOs are no longer enrolling anyone new. Is that throughout the entire state of Georgia?
That is up to the individual plan to make the decision on where they feel like new dentists need to be added. That is something that they do get to decide.
So let me ask you a further follow-up question. In an area that might not have adequate dentists or something to that effect, if someone's running the risk of going in and buying a practice or trying to take over a parent's practice when the parent wants to retire and sign up new, there's no guarantee they can or can't, isn't there? I mean,
that is correct.
So therefore, a dentist could come in, buy a practice, and then have absolutely no idea if he can treat the patients, that there's no consistent guidelines. It's all a gray area and sort of, as opposed to some rules or regs that this dentist could read to know whether or not he could in fact treat the Medicaid or peach care children here.
In that particular situation, it would be expedient for that dentist assessing whether to buy a practice or take over a practice to check with any of the dental administrators in that community, not just the CMO dental administrators, but any private insurance as well, to find out what their particular status on network is at that point. It would just be part of good business.
And I will later, so thank you.
Kathy, I want to thank you very much for being here and representing your department. And thank you for partnering to be here. I would love to invite y'all to please remain for the rest of the day and tomorrow, because I think it's very important that you hear what everyone has to say, and we would really
I agree with you,
here.
and I will be here and taking copious notes.
And thank you for standing up there today. You did a good job. I'd like to recognize Representative Shell.
Thank you, Mr. Chairman. We are going to take a 45-minute lunch break for members of the General Assembly, whether you're on this committee or not. Lunch will be served in 230 of the Capitol downstairs. We have over 60 people signed up to address this committee this afternoon. I would ask that everybody be back sharply at 1 o'clock. First up is Tom Bauer at 1 o'clock, followed by Martha Phillips. See you at 1 o'clock. Before we get started with public testimony this afternoon, a couple of things I want to mention. One is we're asking the presenters to limit their presentation to no more than 5 minutes. We have over 60 people who have requested to speak, and we're going to do our best to accommodate everybody. But in order to do that, we've got to stick strictly to the time schedule. Somebody over here will hold this up to the presenters when there's 1 minute left in your 5 minutes, so you can go ahead and wrap it up. We will have time for, we don't have necessarily time, but we will make time for limited questions from the committee. If you just got a burning question you just got to ask, if you will press your button and we will recognize you. But the purpose why we're here is to hear from the public. But if you do need some questions, go ahead. Our first presenter is Tom Bauer. And if you would, it's not necessary, but if you do have handout material prior to your presentation, give that to staff. And if you would, when you start your presentation, tell us who you are and who you represent.
Thank you, Mr. Chairman. I'm Tom Bauer with the Georgia Occupational Therapy Association. Kay Nelson is going to be doing our testimony, and I'm going to give you a handout that we gave your committee in February this session, and with the bullet points, and there's nothing changed, I regret to say.
Hi, my name is Kay Nelson. I'm an occupational therapist in Gwinnett County. I want to speak to you on behalf of children in Georgia and children with special needs specifically. I listened to Kathy and Dave this morning talking about all the data and the numbers, and I appreciate that. I know that we're about saving money, and we need to do that. But we also need to realize that these are children and these are families. I want to tell you a little bit about a 3-day-old child that one of the CMOs called our office and asked us if we would see. The child had an injury to her arm. We said, it's from the CMO, surely they'll get this one right. After waiting 3 days for permission to evaluate the child, we did that. We recommended some limited therapy, and we waited 3 weeks for permission to see this child for therapy. We called every other day. We had to fax the authorization 3 times before they would acknowledge that they even had it. At that point, after 3 weeks, this mother, a first-time mother, called our office crying and said, "I haven't bathed my child in 3 weeks because I'm so afraid I'm going to hurt her." I'm sorry, but that's not forgivable to me. I don't understand that. That is our experience. That is the experience that the therapists of Georgia are having with these CMOs. We call, we ask for an authorization. We call daily, we ask for another authorization, the same one over and over. We fax the same one over and over. When we do get permission to see the children, we then bill for it. Sometimes we're paid, sometimes we're not. Sometimes we're paid the correct amount, many times we're not paid the correct amount. We can't get people to answer our questions. We need help. We need answers. We're willing to work with them, but it takes both ways, okay? Several of you asked questions about access, and that's an important issue. We have families that call our offices and say, "Please, please, will you take my child?" To be honest, it depends on the day. It depends on how bad our experience for the past week has been with the CMOs and trying to get paid and trying to get authorizations. If it's been really bad, we throw up our hands and say, "We can't take anymore. We can't do this anymore." If it's been a little bit better, then we might try to take one more in the hopes that things will get better. But to be honest, as Tom said, we've been doing this since June of last year, and we're still trying to collect money owed to us, many providers are, from June of last year. That's difficult. Many providers in this room are experiencing the same thing. I know it's not just therapists, but these are children. These are tiny children that need help. I want to tell you one other story, and then I know there's a lot of other people that want to talk. I have a young child, a young daughter. We received a call from a parent not too long ago saying, "Please, will you see my child? I'm in a CMO. I've begged everyone. I've called around, and no one will take my 8-year-old daughter who had cancer of the brain and had surgery in February. She needs a walker so that she can get up and go to the bathroom and come to the table and be with our family. We've called around for weeks and weeks, and no one will take my child." We took her. We've been seeing her for a little while now. We can't get paid for her. We can't get the authorization straightened out. But we're seeing her because I can't turn those children away. And I think that's the honest opinion of many providers in this room. We want to do the right thing, but it's become almost impossible. Thank you.
Thank you very much. Martha Phillips.
Thank you, Mr. Chairman. I appreciate the opportunity to address your group. As Kathy Driggers said this morning, sometimes you have to look back at the past to know what you're doing in the future. And I want to give you just a little bit of a history about what's happened with dentistry as far as children are concerned. Georgia's Medicaid and Peds Care children have had a really bumpy road as far as accessing care for a long number of years. And I want to be real clear, it's not because we don't have enough dentists to provide the care. It's quite honestly because of the yo-yo effect that we've been having with all the changes in the program. Back in the 1980s and through the 1990s, quite honestly, very few dentists could afford to take the children. They had so many administrative hassles. The fees were extremely low. It was just a very, very difficult process. As a matter of fact, we got to the point in 1999 where we had less than 250 dentists who were willing to see Medicaid patients on a regular basis. And because of that, the state came to the GDA and they said, help us get access for these kids. And we said, we'll do everything that we can do to help you. So we did a Take 5 program. We asked every dentist to take a patient one a week, one a day, one a month, one a year. Do your part and Take 5. And so we had started the climb back up in the early 2000s to getting more children seen by a dentist. And then, and as Kathy mentioned this morning, in 2003, we all went through that chaotic time when the state changed their administrator from EDS to ACS. And quite honestly, it was amazing that we had any dentist who hung in with the process, because ACS wasn't ready to take that project on. And when they took it on, they ended up having to make prospective payments to dentists that as much as a year later they were coming back and trying to collect money from dentists because they had either overpaid them or paid them for the wrong patient. I know that the state lost millions of dollars in that case where they could, providers were out of business, not dentists but other providers, and they couldn't recoup the money. So the history is that we've had a problem in being able to provide access to dental care, again, not because of the dentist but because of the process. And then we were just kind of leveling off after the ACS EDS debacle, and what happens is in 2006 Georgia's going to go to managed care for dentistry, and you know, we said, look, we're up for giving it a try. We know that in other states it hasn't worked very well, but dentists are willing to try, and so we got dentists to again continue to sign up for the program. And I want to tell you, this has been the most dumbfounding thing to me that I have ever experienced in my life. 4 months after the CMOs started the program, they came to us and they said, Martha, we have a problem. And I said, what's the problem? Too many kids are utilizing services. Too many kids are getting into the program. We've got 70% of the children who are getting to see a dentist. And I said, this is a problem? You know, I really was surprised that they thought 70% was too many, because I have to hand it to them. They did a really, really good job of going out and educating the patients about their benefits. They made it very easy for patients to connect with a dentist because they have a 800 phone number, so that any patient who wanted to get access to a dentist, all they had to do was pick up the phone and say, I need to see a dentist in that area. And quite honestly, before that, it was much more difficult for a patient to connect with a dentist. So the fact that they were surprised just shocked me. And you know, one of the other things that several of the CMOs did is, as an incentive to get people to sign up for their program, they actually gave away adult dental care to their members, cleanings over a period of time, if you would sign up as an incentive to get them to sign up for their plan. So the fact that 4 months into the plan they're complaining because too many children are getting in to see these dentists really just totally astounded me. I mean, you know, and I still have a difficult time with that. In this packet of information I've given you some facts about utilization, and I just want to tell you what the utilization was in 2006. According to the department, this is the fiscal year in before we started with the CMOs, 61% of the Peach Care children were able to access dental care, and 36% of the Medicaid children were able to access dental care. So all of us really should have been applauding the fact that we all did a better job. The dentists were doing what they were supposed to, and the CMOs were getting them in. The CMOs also came back and they said, well, let me just tell you, Georgia's dentists are being paid more than other dentists, and I have a chart for you in your packet, quite honestly, that compares us with other states, North Carolina, Tennessee, Texas, and Virginia, and Georgia's fees are not higher. This chart clearly shows that our fees are in line with what the other states are around us. So again, it's not because dentists are being paid too much. And by the way, these fees are the fees that were being paid to the dentists before the cuts that are currently being implemented now. So Georgia's fees would look a lot less than that now. You know, one of the things that you heard earlier is how many contractual changes dentists have had, and I want to tell you that's the one thing, and Kathy was very good about saying we could have done a better job with that, and I appreciate the fact that she took the responsibility. I know it was the CMOs and the subcontractors that really put the communication out, but the truth of the matter is any dentist, or any provider for that matter, should have clear contractual terms. They should be able to know what it is that is expected of them. most dentists started the plan when they started back in June of last year, and it was weeks, not days, but weeks before most of them got their provider manual. So we've not had clear communication from the CMOs since the very beginning.
Your time has expired. Let me, again, if you all would pay attention over here, they're holding up when it's 1 minute. I do have one question for you. Ms. Driggers mentioned in her presentation that something that CMOs or HMOs had in their toolbox for a long time was that if you limit the provider network, then you will limit utilization. Would you agree with that?
I heard her say that this morning, and you know, if utilization means that it will get fewer children to come in and see the dentist, I guess with fewer dentists that's probably true. You know, the one thing that is very important in dentistry is you absolutely have to get children in for that preventive care, because if you don't, you're going to spend more on the restorative care. So I assume that's what she meant by utilization.
Thank you.
Thank you.
Dr. Lois Nella, M-A-N-E-L-A.
My name is Lou Mamelli, and I'm an OB physician practicing in rural West Central Georgia. Thank you once again for the opportunity to speak before the committee. I'd like to begin my comments by addressing a few specific problems among many regarding the Medicaid CMO model here in Georgia, and then I'll broaden my comments as I conclude. For specifics, I'll start with the problem of Medicaid enrollees' ability to switch between CMOs in the first 3 months when it fits their need to obtain a service they cannot get with the CMO to which they already belong. In the course of a medical event such as pregnancy, this means my practice has to continuously bounce between what requires pre-authorization for one CMO and what doesn't for another, who to submit claims to and not to, what forms need to be used for one and not the other, and where to fax them, which ancillary providers are and are not contracted with each CMO, and who the network of providers are for referrals to each. Talk about a perfect storm for inadequate patient care, and you have it right here. When we pre-authorize a service, when we pre-authorize a service at the end of each month, but the date of service is early the next, and the patient has changed CMOs, you can imagine the nightmare for both the patient and us. In our opinion, this administrative nightmare is correctable if only the state mandates that all the CMOs adopt uniformity in their administrative processes or drop those they refuse to unify, and beneficiaries are required to stay their course of care with just one CMO. Next, 15 months into my participation with the CMOs, we still can't correct claims online as we can with traditional Medicaid using ACS. This promise by the CMOs dates back to implementation and remains unfulfilled. This problem doesn't help my cash flow. This problem strains the operation of my business. This problem squeezes my bottom line, and this problem allows the CMOs to hold on to the taxpayers' money far too long and likely leads to their profiting from it. Third, customer service remains extremely problematic. The only positive is that we can generally reach a provider rep or customer service agent within a day. However, addressing or solving our problem is another matter. Techniques that we commonly employ to cut through this long delays include calling back repeatedly with the same question to talk to different customer service agents until we find one knowledgeable enough to help when most contradict what our provider reps have already told us to do. Another is to call back repeatedly after faxing in forms, then demanding a verbal acknowledgement that the fax actually got into the hands of someone who knew what to do with it and was actually prepared to accept responsibility for getting it into the system. We have also had to contact contact the DCH Division of Managed Care and Quality to ask Ms. Mayfield to intervene on our behalf, pressing the CMOs to deal with our issues in a timely and definitive manner. As you can see, customer service appears to us to be a very low priority with the CMOs. What has resulted from CMO implementation can be summarized in the following way. When an OB patient is 41 years old, smokes 2 packs per day, tests positive for cocaine throughout her pregnancy, has a baby already 3 weeks behind in growth at the beginning of her 3rd trimester, and she is denied weekly ultrasound monitoring, there's a problem. When a 95-pound female obstetrician in a non-teaching rural hospital has to perform an emergency C-section on a 330-pound woman, but is told an assistant surgeon is not medically necessary, there is a problem. When the complexity of managing and delivering a high-risk twin pregnancy is judged not to be deserving of CPT and ACOG-appropriate adjustments and reimbursements, there is a problem. And when the CMOs defend these actions by arguing that there are avenues available to challenge these claims denials, if only the providers would, 1, submit the mounds of paperwork demanded, 2, navigate the maze known as provider relations, 3, wait for it to reach medical review, 4, obtain an audience days later with a physician reviewer, and then 5, further dedicate the time away from patient care needed to complete the game, there is a problem. In the short term, like many of my colleagues, I have made the adjustments which can be made to survive. This has been especially difficult in rural Georgia, where 50% of my GYN and 70% of my OB are Medicaid beneficiaries. But with rising overhead, shrinking reimbursements, increasing denials of lack of medical necessity, fatigue is quickly leading to exhaustion. I am a 51-year-old physician and the youngest in my group. I no longer have a 5-year plan or 10-year plan to grow or even maintain my practice. The senior physicians in my group, as they cut back and leave, will not be replaced. We'll cut employees, we will cut benefits, and shrink our practice. I applaud the committee's willingness to take public commentary. I encourage you to look for solutions to the providers' problems by relieving us of suffocating and unnecessary administrative burdens. I believe you should challenge the CMOs to put as much energy into recognizing and reimbursing providers according to CPT guidelines as they put energy into hiding behind CMS guidelines in their corporate strategies to deny payments for lack of medical necessities. One of the CMO achievements has been reported to be 90% approval on pre-authorizations. But what they don't tell you, as is in my case, if I challenge the other 10% and run the obstacle course I'm asked to run, I will get approval. So I leave you with a question. Why not let me invest the enormous time commitment I make every day to the CMOs and instead invest it into patient care? Why not let me practice medicine and eliminate the administrative burden that ultimately serves no purpose other than to deny services to patients and payments to providers? I appreciate the time.
Thank you, sir. The chair appreciates how difficult it is to get said what you want to say in 5 minutes. And I'm sure that many of you could speak for hours on this, and if we had the time, we'd be quite willing to listen to it. But we do have over 60 folks, and in an attempt to move this along and being courteous to others, and then there are a lot of people in this room who traveled a long distance to get here. They got to travel a long distance to get back to where they came from, including the gentleman that just spoke a while ago. And so what the chair's going to do is, from here, let you know when there's 30 seconds left, and ask you to summarize your remarks so we can finish this today. Thank you very much. Harris Morgan. Yes, ma'am. Staff will get them to you if we have enough of them. If there's not enough, we'll make sure you get copies before the end of the day. Harris Morgan. Last call, Harris Morgan. Don Crawford.
Thank you for allowing me to be here today. My name is Don Crawford. I'm the Executive Director of the Empty Stocking Fund. We're a nonprofit organization that provides Christmas toys and gifts to underprivileged children throughout the metropolitan Atlanta area. Our client base are children aged birth through 13 who are Medicaid eligible, and therefore our relationship with AmeriGroup developed. The season before the open enrollment period, AmeriGroup and I developed a partnership where they provided some financial support to us, which helped us buy the toys and gifts, but also set up an educational booth at our distribution center where they met with the families that came through our facility and provided an educational service to those families about the options that they would have available to them and gave them some information that they could take with them. Since that time, our relationship with AmeriGroup has evolved, and they've become a very strong ally of our program, helping us with much of our community outreach efforts. We have found them to be a very professional, very dedicated group of people who seem very focused on helping our community. I can't speak to their core business functions. That's something that's outside my square. But we have found them to be a very dedicated group of people who volunteer at our facility, assist us with our outreach efforts, and one that we're very pleased to have as a partner of our organization. So I came today to speak on their behalf and to tell you that we have found them to be a very professional and credible group. Thank you.
Thank you. Earl Rogers.
Good afternoon, Mr. Chairman, Chairman Janelle, and Chairman Goggins, members of the committee. Thank you for taking time out from your day to listen to our testimony about how we believe things are going with the Medicaid managed care. My name is Earl Rogers. I'm employed by the Georgia Hospital Association, and we represent the 174 hospitals in the state, including the general acute hospitals that provide health care services to the Medicaid population. And I want to say I think that was a great presentation this morning by the department. I thought they did a wonderful job. I thought the slide presentation was very good. And I'll say this in all seriousness. If we can get this program to work like was shown up there on that slide presentation, then we'd have and I'm not saying that to be funny. I mean that. It was a beautiful slide presentation. I think you did a great job. I applaud the department for designing a program. But if we can just get it to work like that, then we'll have a great program indeed. It's been a year and since the state has implemented the program. And as with any new program of this magnitude, we knew there were going to be problems and challenges. We knew there'd be growing pains. Providers, including hospitals, have tried to be patient. We understood it was important to partner with the CMOs to provide quality services for the Medicaid population. But again, it's been a year, and I just want to take a minute to talk about a few issues that need some real attention. First, the move to Medicaid managed care was based on the premise that the state could both save money and improve quality of care by hiring the Medicaid HMOs to actively manage the care of the 1 million enrollees. A centerpiece of this concept, and one that was much espoused by all the CMOs, was a promise to identify individuals who use hospital emergency departments or primary or non-urgent care and redirect them to less expensive care settings. But it's been a year, and we have little evidence that the CMOs have hired the necessary personnel to help fulfill this promise. We still have so many people going into the emergency rooms and not being redirected. The state is paying the Medicaid CMOs hundreds of millions of dollars annually for this kind of services, and the question arises whether there is evidence to demonstrate that the CMOs are living up to their end of the bargain and committing the resources necessary to manage the care, or by denying, or the CMOs are reducing costs to the state by denying access to services or making their profits by cutting provider payments. We believe the evidence is clear regarding how the CMOs are actually doing business. Let me mention one example of the systematic way the CMOs are underpaying providers in violation of not only the spirit of the program, but also the terms of the contracts. Since implementation, hospitals have reported that the CMOs are paying true emergency claims at the much lower triage rate, which is $50. Most cases is $50, which is the same as the non-emergency. That's what triage means. That's in violation of the federal prudent layperson standard that's applicable to such claims. In response to these calls, DCH hired a consultant. The consultant found out that one CMO has got their system automatically programmed to turn down 80% of the claims, and of the emergency claims. When we go back and appeal those, 57% of those are overturned. So they got a 57% error rate in their claims processing to the detriment of the patient and of the healthcare provider. Second point I want to make is that while the state may have saved and the federal government may have saved $240 million by moving to managed care, there have been significant costs to the healthcare delivery system. A lot of people don't realize that when we moved to Medicaid managed care, we also right off the bat lost access to $70 additional million because of a complex federal rule that says that if you have underpayments of Medicaid, that you can't get those back if you've got Medicaid managed care. This is an annual loss to hospitals. There's one very important and immediate issue which we'd like to bring to your attention. Hospitals need reports in order to claim almost $400 million in Medicare DSH funds, disproportionate share funds. Before the move to managed care, DCH provided these reports. Now the department says that the CMOs will provide the reports, but because that is not in the contract, we are left uncertain as to whether we will get the reports. So I would encourage this committee and I would encourage the department, and when you talk with the CMOs tomorrow, please encourage them to provide those reports because it means $400 million to hospital providers. Lastly, I want to thank you for this hearing today. I would ask you to continue to exercise your oversight authority over this issue. We'd ask you to do three things. Please ask the CMOs to honor their contracts. Please ask them to hire the adequate number of staff to act as case managers so as to redirect these frequent users of the emergency room to a less expensive venue, and provide these necessary reports so that we can have the proper claims to the Medicare DSH funds. And to the state, I would ask the state and the lawmakers to strongly consider raising the Medicaid rate. We have not had a rate increase in Medicaid for over 5 years. And when you're paid at 85% of your cost, it's very difficult. Yes, sir? Wind it up. I got it, yes, sir. The last thing I want to say, and I think Representative Setchler said it, apparently he and I read the same book, Stephen Covey's 7 Habits of Highly Effective People. Always look for win-win. I would say win, 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 and win. And I would say taxpayers, providers, CMOs, and most of all, the patient. If we can partner together, we can make that happen, and there's no reason why we can't do that.
Thank you, Earl.
Thank you, sir.
Amy Hughes and Representative Senator Mike Pollock.
Mr. Chairman, members of the subcommittee, and my friends from the General Assembly, it's great to be back. I am now the Executive Director at Memorial Health, with responsibility for marketing, government relations, strategic planning, and the community outreach. So who I brought today is Tracy Thompson, who's Director for Public Policy for Memorial Health. She's going to talk a little about just examples and some testimony on behalf of the hospital's dealings with the CMOs. I do want to recognize, as the Chairman mentioned, Amy Hughes. We're a client now of the Hughes Public Affairs Group, so it's great to have Amy continue on board with Memorial Health. So, Mr. Chairman, for the sake of time, let me turn it over to Tracy, and then I'll close with a couple of comments.
Thank you for being willing to listen to this testimony about this important issue. Memorial Health has 36% of our patient population is Medicaid enrollees, and 70% of that is in Georgia Healthy Families. So this is a big issue for our organization. We agree with DCH that Medicaid managed care is a good tool for controlling Medicaid costs and improving the health of patients. And as you've already heard, if it needs to be implemented in a better way, it could really give us some good results. So I'm just going to give you a couple of examples as far as affecting quality and accessibility of patient care. As you've already heard and you know, there's a shortage of physicians in the state, and they're currently being reimbursed at approximately 85% of cost. The operational problems in the CMO program exacerbates this and has created disincentives for physicians to sign up. For instance, one disincentive is physicians who are still not listed as participating even 1 year out from signing up and not being paid their full fees as a result of being categorized out of network. Another specific example is the fact that there are 11 pediatric orthopedists in the state, only 2 of which accept Medicaid CMO patients. These circumstances are very onerous for this population since these patients are more likely to have limited ability to travel. Additionally, for our organization, the business inefficiencies are an issue. WellCare itself reported that 60% of the ED claims it denies are eventually paid. Our staff reports about 93% of those denied claims are eventually paid, but that's usually after several denials and appeals. Our staff has gone from about 15 to 20 hours a week on Medicaid billing and appeals to now 90 hours a week on this single payer source. These issues have wreaked havoc in our organization's ability to be efficient.
You know, looking at this thing from a former legislator's perspective, if you look at this situation, you really have 3 solutions. Three things you really have to address and find solutions for. The first one you'll hear over and over again today is going to be the adherence to the CMO's contracts. That will resolve a lot of issues in itself, and I hope you'll press the CMOs tomorrow on that and continue conversations with the department on getting those done. The second issue we're going to have to address is this denial process, where in a lot of situations 4, 5, 6, 7 times we're getting denials done, and as Tracy indicated, those eventually are being paid for. So you're driving inefficiencies in the process for our operations, which I know is not what you're intending to do. The third issue I think is more core and that we're going to have to address, and Tracy touched on this. You cannot compete and have the market drivers within the CMOs that you need to have if we continue to pay healthcare providers 85 cents on the dollar for cost. If you continue to do that, you're not going to have providers want to get into the Medicaid delivery system. Down that path, there's a lot of questions from members of the committee, rightfully so, about access. We have a situation in South Georgia where we do not have one pediatric orthopedic surgeon handling the area. We have 2 providers in Chatham County. One won't come into the CMO program. One is in the program, a number only, but won't accept patients. The reason being, one, it's difficult, have problems, those can be addressed. The second issue we have to address as a legislator is that 85 cents on the dollar. Again, market drivers have to be there. We all recognize it. You should have physicians that are competing for these patients. Once they compete in a competitive environment, quality will go up, and the benefit and the overall health care of these individuals will go up as well. So help us create a more competitive environment, rethink, look at a reimbursement rate that hasn't gone up in really 5+ years, and I think that's a core issue. We address that. Some of the other issues will shake out. Thank you.
Thank you. Dr. John Moore.
Thank you, Chairman Goggins and Chanel. Appreciate you letting us be here today to look into this very important issue for the patients of Georgia. I'm John Moore. I'm an OBGYN. Have offices in Northside, up in Alpharetta, and up in Forsyth County. I'm past president of the Georgia OBGYN Society, past president of the Atlanta OBGYN Society, past chairman of Northside Hospital OBGYN Society Department, and I'm currently representative to the American College of OBGYN from the state of Georgia. There are several problems, but I just want to touch base on a few, plus offer some suggestions that I think will help us to provide care to our patients, which is ultimately what we want. We want to provide the same care, quality that we do to all our patients, to the Medicaid population. One of the problems we have is patients are not assigned to a CMO early. I know there's some federal regulations about they can change, but this creates a lot of billing issues. To start with, a patient is in regular Medicaid, and then sometimes they'll come to our office, then they'll get on a CMO, so now you've got two places you have to send bills to already. This creates inefficiency and more time in my office. Also, there are some physicians who won't take the patient until they are in the CMO. And as Ms. Drigger said, this can take sometimes up to 8 weeks. And so if that patient needs care, she's having to go to the emergency room. And anecdotally, many physicians are saying they're now having to see more patients in the emergency room than they were seeing a few years ago for this very reason. So if DFACS could get the patients, even when they sign up for Medicaid, to go ahead and sign up for a CMO, that would help eliminate that problem. In addition to that one, AmeriGroup is wanting to do away with the global fee. They want to do each visit individually, which that's going to create a logistic nightmare for billing out. It's going to create more work for our office, more work for the CMOs, more work for the state, and that's going to be a waste of money and a very inefficient process. So that needs to be nipped in the bud. The pre-certifications, particularly with WellCare, are very onerous. We used to be able to take care of the patients and do what was right. Now many times these pre-certifications are being required, which many times we don't have time to do them. A pregnant patient comes into my office and says the baby's not moving. I need to do an ultrasound there to check that baby out for well-being. Either I do it in my office, knowing I may not get paid for it, but I've got to pay my technician and everything, or I send her to the hospital. If she's in my coming office, that's an hour drive down to Northside. That's not convenient for the patient. It's more expensive on the health care dollars, and it's ridiculous. Things like that we should be able to do in our office because it's just plain good patient care. We shouldn't have to jump through all these hoops. All of these also have different filing times for our bills. Some are 2 months, some are 4 months, some are 6 months. That needs to be uniform and probably up to 9 months for timely filing because some of the patients have 2 different carriers. They've been on one, they switch to another. They have a regular insurance with Medicaid secondary, so you have to file one, wait on that response before you can file the other. And many times that will create a delay in filing, and then you end up filing the last one, and they say, oh, sorry, too late. We appreciate you doing the work, but you're not getting paid. And that's not fair to the providers. Lastly, this was addressed earlier, we've been very proactive in the Georgia OBGYN Society about having access to care for our patients. 15 years ago, there were no OBs in the north side of Atlanta that would take Medicaid. I personally worked on that because I thought it was the right thing to do. And now there are plenty of providers there. But fees have not been increased in 5 or 6 years. That is creating a problem with some of the practitioners. And that is one of the things that will need to be addressed because we always want to make sure that we do have access to care to our patients. We want to get the patients into the office because we do know in the long run when the patients are seen and taken care of, there's a great savings at the end because if they're not, then their cost later is excessive. Also, Ms. Driggers, the things she talked about earlier, those programs, they're very good. Unfortunately, many of them are just fairy tales right now. The perinatal outreach has not really been effective or put into effect. I hope it is. The way she described it sounded excellent. And we're glad to work with her on that so that we can make this a reality to provide better care for the patients of the state of Georgia. Thank you very much.
Thank you. Thank you, Doctor. Ken Beverly.
Thank you, Chairman Goggins. Thank you, Chairman Chanel. Thank you, the members of the General Assembly that are here. We appreciate it very much. I'm Ken Beverly. I'm from Thomasville and with the Archibald Medical Center. Want to applaud Kathy Driggers. I think Kathy, and I have said this, I've known her for years and years, is probably the hardest working person in this state. I think she has been focused on this issue, and I think she has worked diligently along with the entire DCH staff to implement a solution and a problem that they were asked by the governor to address. I have been at Archibald for 34 years, followed Medicaid and other things pretty well through these years. Unfortunately, when the department negotiated these things with the CMOs, there was no General Assembly oversight, and I really don't think there's any insurance commissioner oversight. Oxidine is going to be in Thomasville tomorrow for a ribbon cutting for our telemedicine thing, and we will talk with him again. I think it's the DCH board and the governor's staff and whatever. But coming on back around, the concern for the beneficiaries is foremost in all of our minds. I was chairman of the Georgia Hospital Association, and Joe Parker, the president, and I met with Commissioner Burgess back in 2003, and in your packet there you have a letter that I sent to the commissioner and position paper and things like that. And we pointed out in September of 2003 that our concerns were that a Medicaid HMO would adversely impact patient access, that health care dollars would be sent out of Georgia, we would not reduce administrative costs, that it would strain the Georgia health delivery system as we know it, and that a Medicaid HMOs per se nationwide have not had a positive track record. They haven't been tested. As we look, and I'm not going to give great examples for all of those things, or a bunch of them, the dollars are leaving the state. We talked about going to New Jersey or Connecticut or whatever. Administrative costs have not been reduced. The delivery system is fragile. It is in shambles now at Grady and several other places around the state, and is rapidly degenerating and disintegrating from what we knew. Today, hundreds of millions of dollars are leaving this state, and if we leave here with just one thought, and it is simply stated, we were talking about roughly $6.5 billion for Medicaid, and that was too much money for Medicaid, and it was going up 10 and 20% a year. Only about $1 billion went to doctors and hospitals. Now, that's a lot of money, and there were maybe 1 million and 1,000,001 recipients on that or whatever. Now, folks, we have sucked out of about $1 billion. We have sucked $200 or $300 million a year. The department did a great job running the Medicaid program for about 5% overhead, 5% cost of what it did. Those folks over at Medicaid did a fabulous job. We are paying the CMOs 15 to 20% to do, so we're taking a couple of $100 million for overhead and profit, and then we are losing all this stuff on this upper payment limit. And where I used to at Archibald could contract with Medicaid, if I had a Medicaid contract, they would recognize that Archibald was disproportionate and we needed some extra money or whatever. But now I don't have a contract with Medicaid anymore. I have a contract with two CMOs. Coming on around with some eligibility, there's some dollars left on the table, but coming on around to the simplicity word and the solvency word. Our collections are way down. When we went into this thing about last September, we had about 6,000 patients or whatever. That number's gone up towards to 10,000, where we're in a rear zone, and there's about a $5 or $6 million additional money that the CMOs have, so I hope they're solvent. If everybody's contributed, like my organization, back to the previous speaker here, of the solvency of keeping the taxpayers' money. We have added 4 full-time employees just to process this stuff. In addition, we used to have one payer, and that was the Georgia Department of Community Health and the state Medicaid program. Now we have 4 payers, And we had systems that talked to each other. And anyway, so coming up to, for the simplicity, it has gone up exponentially. Access is a dilemma. People are shutting down clinics. So we used to give huge amounts of money to health departments, things like that. Those things are all going away. And I would conclude with thanking you. I would encourage legislative oversight on this thing, as well as the insurance commissioner. And we want to thank the department. We've appreciated the Georgia Medicaid program. There are a lot of things going out there. The train's coming off the track. Grady Hospital is one of them. Thank you, sir.
Ken, Chairman Goggins has a question.
Sure.
Quick question. How much in the UPL have you lost over this year?
How much indigent care do we do at Archbald?
Now, how much of the UPL dollars have you lost so far with Indigent Care Trust Fund?
Oh, I think we've lost $3 or $4 million. And I think the state is going to lose about $100 million in round numbers. And it's going to be annual. And, we appreciate the governor going up and testifying for Peach Care. I mean, they're not a provider in this room that doesn't thank him for that. But we've left an equal amount of money on the table that the federal government paid on UPL that is just not recognized. Okay. I think there's a lot of unintended consequences on that.
And your unresolved, what's your reasons for that? The increase in the unresolved accounts?
Oh, the same thing. If the claims are denied, they're sent back automatically. They're rejected. All of the things that come with that. 300 a week we're having to reprocess. We have a huge success rate in getting them, retroactively approved, but they're just categorically denied. So we have 3 people, and we're going to add 2 more. Thank y'all.
Thank you, Ken. As an aside, in the time that I've been doing this job, you've been before this committee many times, and you're very articulate, and we've never misunderstood what you had to say. You're very... Thank you for that. Vicki Madden.
Hello, my name is Vicki Madden. I'm here as a parent. My child was diagnosed in 2005 with Down syndrome. I never thought I would be in this predicament, but I am. And my child, I am one of those new class of people who have insurance. I work, but I'm underinsured. My child has WellCare as secondary insurance, and health care providers will not touch him because of it. I have waited 4 months to get a speech therapist for my son because once the private insurance limits ended, I had to pay out of pocket, and it's very expensive. Also, I have had to wait for an occupational therapist. My son has to have several therapists, at least 6. And he has seen 6 doctors, more than I've probably seen in my whole entire lifetime, and he's still under those doctors' care. This whole process has been horrific. While he has insurance, no one will touch him, as I said, because it's WellCare. He's a participant in Babies Can't Wait. So far, many of the Babies Can't Wait providers have not been paid. They've been told that if they, in good faith, submit their information for approval to become a WellCare provider, that once they're granted approval, that they could, in the meanwhile, go ahead and service these children. Well, one of the providers serviced my child, and she has not been paid in over a year. I have a bill outstanding, and WellCare will not pay. They have approved her. It took 2 years for her to get approval, and now they will not pay the bill. While I'm fighting with WellCare as a parent, I'm also fighting with DFACS, who now wants to close my child's temporary Medicaid. I'm fighting with the Department of Community Health, and when I say fighting, I really am fighting as a parent. This is totally unbelievable. In March, in February, I applied for the Katie Beckett package because I do not meet any of the other state or government funded programs. So I had to apply for deeming waiver. I have done that. On March 14th of 2007, I received my first denial letter. Although SMU has determined that my child is disabled, the state of Georgia Department of Community Health Division has determined that he does not reach the level of care, that he does not meet all the criteria for rehabilitative services. I can't get rehabilitative services because of WellCare. In May 22nd of 2007, I received my final denial notice, although I did provide supplemental information from all of my child's doctors, plans of care, various evaluations that were done on him. I have filed an appeal. It's pending. I filed that appeal June 21st of 2007, and I'm still in limbo. My child needs medical services, not only my child, but other children in the state of Georgia who have disabilities. Now, one thing I can say, either Georgia can decide that they're going to help that the state is going to help children now, or they will incur more costs in the long run. Children have potential. There are children with disability who have potential, great potential, but they need early intervention. Babies Can't Wait is a great program, but my coordinator for my child has recently informed me that she will no longer be available to me on a regular basis. So a lot of the lab work I will have to do myself. And I have been participating in the process. I have not been a parent who has set aside and allowed other people to take on the responsibility for me. I have depended on Babies Can't Wait for certain resources, but now they can't provide it. They have providers who are seasoned who are now saying, I will not take on any more children because I cannot get paid. I'm not taking any other children for that reason. Also, one of the problems I've experienced with the CMO is that it's not user-friendly. Parents are the greatest advocate for their children. However, when I call WellCare tells me, you are not a doctor, you are not a physician, have your physician's office contact me. The physicians only want to provide medical services and to get paid for the services that they've provided. As a parent, I should be aware and made aware of the things that are going on with my child and his benefits through the CMO. But I can't get that because I'm just a parent. I hope that none of you all or anyone in your family will have to experience what I've had to go through, because it is a difficult road. It's a difficult burden to carry, but I'm here because I believe that everyone has to go through certain things in life for a reason, and this is my purpose for this moment in time. I am fighting not only for my child, but for all children in the state of Georgia and across this country. And I also have some documents that I want to provide to the committee. And these are just things for you to look at. Providers should be paid for the services they provide. And children should be given the opportunity to develop to their fullest potential. Thank you.
Thank you. Karen Bennett.
Good afternoon, Mr. Chairman, and to the members of the committee. While I recognize that the hour is late, I will respect the rules and I will not repeat the issues that I have that have been repeated before. However, I would like to go on record. My name is Karen Bennett. I'm a physical therapist. I own Metro Therapy Providers, which is a small therapy provider company in DeKalb County. We provide physical therapy, occupational therapy, and speech therapy. In addition, I represent the 1,700 members of the Georgia Physical Therapy Association on the Tri-Alliance, which is an advisory committee made up of representatives from the Speech Therapy Association of Georgia, the Georgia Occupational Therapy Association, as well as the Physical Therapy Association. And I would like to say to each and every speaker that has gone before me, I would like to go on record as sharing each and every experience that they have expressed. So with the respect of this committee, I will not repeat all of those issues, but I will be specific. To the parent that just spoke, I thank you for speaking so eloquently, because we are a provider service that we go out and we recruit therapy providers, and it takes 90 days for the CMOs to credential them. So subsequently, we cannot provide some therapy services because we have therapists that may be accessible and available. However, due to the system, we are not being able to be credentialed to provide services, and subsequently the therapists go and work in other areas. Also, I would like to speak and focus on the accessibility and availability issue today. As many of you know, the pediatric hospitals, Scottish Rite and Eggleston, do not or no longer accept Medicaid for outpatient therapy services, which also presents another dilemma for our children in the state of Georgia with special needs who cannot find therapy providers. So that, coupled along with MUTs and decrease in reimbursement, therapy providers are being forced to leave the program. We're not leaving willingly, we are being forced to leave the program of providing therapy services through Medicaid, AmeriGroup, WellCare, as well as Peach State. Metro Therapy Providers alone since January of 2007 has incurred a reduction in reimbursement at 40%. In January of 2001, we were collecting at least 95%, and now in July 30th of 2007, we are down to 59% because of the first-time denials, lack of authorizations that are being provided and then not honored. We actually have gone through the authorization process, get authorized to provide services by the CMOs, and then later those claims are rejected. The process of getting those claims appealed is very time-consuming and costly. The overhead has surmounted in triplicates, while the revenues have decreased by 40%. This is real. Ms. Driggers and the department presented a very good presentation this morning. The oversight, I'm not sure what's happening, but we're not getting those silent calls. And yet we are calling the department. We are calling the CMOs. We have been escalated to high-ranking officials within all of the CMOs, and to the point that they have received so many calls that they don't even return the phone calls anymore. So we have no place to go. We don't know where to go. And so I would just say, just to be specific of some of the problems, some providers, we talked about the access and availability. The credentialing is a very big problem that I would hope can be resolved. And then the systems issues. While we understand that through a process of change, there may be systems and electronic issues, as providers, we are just asking the help of the department as well as the CMOs to provide a quick resolve. They are aware of the problems, but we can't understand why the problems can't be resolved. So again, children with special needs are losing services that are available. And in the end, it is the children and the families in the state of Georgia that are going without the therapy services that they are in need of. Thank you.
Thank you. Wayne Martin.
My name is Wayne Martin. I'm the CEO of Chris Regional Hospital in Cordele. I speak on behalf of our hospital as well as the Center for Rural Health, which is an arm of the Georgia Hospital Association, about 70 members, half of which are certified critical access hospitals. And at some point in time, I would like to ask Cindy Turner here, who is the current chair of the center, to speak about critical access hospitals. We've both compressed our time. We prepared for longer.
Serve the same health care as people that choose to live in the metropolitan communities. Thank you.
Thank you. I'm sorry. Chairman Goggins has a question, ma'am.
Well, I guess it's more so, Kathy, I'm sorry, I'm going to ask you. Didn't we say with the critical access hospitals when they did the contract negotiations that we would make them whole?
Well, I can tell you in negotiating the contracts, they're not willing to do that. Some are and some are not. The ones that are willing to do that, they don't know how to pay us that cost. So. Well, apparently someone's not communicating that to the CMOs and not overseeing that they do that.
And Kathy, that may have been, I think I'm the one that told this nice lady here, some of the acute care hospitals that are speaking to them that they will be made whole, regardless of the negotiation.
Okay. The plans are actually obligated to reimburse the critical access hospitals on the same basis that we reimburse them, which is 100% of their cost. Yeah. It depends on what you mean by being made whole. They're not being made whole against some expectation of payment, but they are directed to pay them on the same basis that we pay them, which is on the cost.
And I guess that they would not be paid any less from a contractual standpoint than they were getting beforehand.
That is correct.
Okay.
We can give you numbers to the contrary.
There is no guarantee that you will get the same, according to utilization management, that you'll get the same reimbursement level previously. However, you should be paid at the same reimbursement rate.
The federal protection is that we will receive 101% of our cost. So I don't know I don't understand how you're relating reimbursement back to cost. There's got to be a settlement at the end of the fiscal year, which is what we're not getting.
We can talk later.
Thank you. And I didn't mean to get in an argument between whatever.
That's
but
okay.
I will look into more of that because I had made that statement to a group of y'all, so I'm going to make sure I did not misspeak.
Okay.
On that.
Thank you.
Thank you, Kathy.
Rhonda Perry.
Good afternoon. I'm Rhonda Perry. I'm Chief Financial Officer at the Medical Center of Central Georgia, and we're the third largest Medicaid provider on the hospital side in the state of Georgia. And I may deviate from what I handed you to try not to be duplicative of what you've already heard. But we can say we realized a lot of the problems going into this, and we saw the dollars going up and knew the state couldn't sustain it, and we agreed with pretty much lock, stock, and barrel the plan as it was presented today, that something needed to be done to manage utilization because there weren't enough dollars in the system. At the same time, we did caution about the UPL monies, the federal monies being left on the table. We even talked about the data needed in other states. We talked to Texas, other states, and they said, don't be remiss and not get your data that you need to file your cost reports for Medicare. For Medicare DISH, for the medical center, that's about $20 million, and Medicare DISH that at some point we've got to have the data to support. With all that said, we did lose about $5 million on UPL. But we went ahead, we knew we weren't being paid cost, and you also need to understand, you're not talking about negotiating with a managed care company for a patient population where you expect to make money. We're not paid cost now, so we're sitting at a table negotiating for services to provide to a population that we're committed to serve. And much of what I would contend has happened this year with this patient population is because your providers have made sure that they got the care they needed, not necessarily because we got paid, but we did the right thing. With all that said, we entered into the contract, and I think maybe the biggest example I could give you, we compared at the medical center to see, have we really managed care or utilization or what has happened? If you look from the period of September of 2006 to April 2007, and then we compared that to the same time period the year before, we experienced a 1.2% drop in our Medicaid utilization. However, for that same time period, we've experienced a 34% drop in reimbursement. Now, that doesn't have anything to do with are they paying the right amount? If they're paying at 97% or 98% clean claims, we could show you $1.6 million in underpayments where they may have cleared the system, but maybe they haven't paid correctly. That's a $10 million reduction in payments for us. And I will just quickly touch administrative issues. You've already heard the issue. Ms. Driggers pointed out newborn babies are not made eligible in a timely manner. We're talking about neonates that are transferred from other hospitals. This has been going on since the day we signed our contract, and we still haven't been able to work it out. We're to the point, and you have an attachment in here, where we're having to go to an administrative law judge. The babies were there. We provided the care. It just seems like a lot of hoops. And then we talked about, the large-scale implementation. Has it been successful? Well, as a provider, we would contend that when we still have doctors since June that haven't been loaded correctly of last year. We have ancillaries that are paid based on, for example, labs are paid on a Medicare fee schedule. We haven't gotten Medicaid fee schedule loaded yet. We have hospital-based clinics that haven't been paid. We have urgent care centers that the CMOs, when we interviewed, were excited that we had as an alternative to the emergency room. Those still can't be loaded and paid correctly. We went where we don't have ambulances where they can be paid correctly. I have dollar amounts in my detailed testimony. But we contend that there's a point where a year and plus to get some of these things cleared, it's time for some of these to be fixed because we're providing the care, we're doing the right thing for the patient. But at some point, when you have all this backlogging, something's got to be done or the providers are going to have to cut access. We're talking about is access adequate now? What will happen? We went, when we testified last year, we had about $2 to $3 million in outstanding Medicare reserves and receivable. We're approaching $7 million now. We have approximately 15,544 accounts for almost $13 million that are over 90 days old. We're just asking to work through this. We believe in the concept, but what we're feeling right now is a partnership where the provider, the frontline people at the hospital are sitting with the mothers and the babies that are crying, trying to get assigned to their primary care provider because in our clinic, 1,100 patients got assigned wrong, and they're trying to help them get them signed back up. The providers are trying to do the right thing, but the denial of dollars seems to be the overwhelming issue right now. And we would say in good faith, work with us. If ambulance claims haven't been able to be loaded in over a year, write us a check, do something, go through the claims manually. But please help us because we are committed to providing the care to these patients and want to continue to have the access that they need to be a partner with the state and to be a partner in our community. The final comment I'll make is we're also very anxious. I've not heard anyone mention this. We're moving to new DRGs and groupers January 1st. We've rebased, and I might add, bringing the groupers up to date, budget neutral, which is going to be a $20 million reduction in having to get those groupers in place. If these companies can't administer this old stuff, we need to get it cleared. We're not saying we strongly applaud moving to new groupers, but we don't need more administrative confusion over those new groupers and this old data cleared up. I'm sorry, I didn't mean to run over. I will stop. But we really feel like right now the providers are experiencing denial of care through technical issues and not true managed care, and what's being provided is by our staff.
Ms. Perry, I have a question that won't kind of get your time. Would you go back to what your handout says and what you also said, and that is you had a 1.2% drop in Medicaid visits over a comparable period of time, but you had a 34% reduction in reimbursement, represented over $10 million. I mean, something don't add up here. I mean, I'm assuming that CMOs are supposed to be paying, at least as a benchmark, the Medicaid payment rates that were in effect when we started. What is y'all's analysis of how could this happen?
Part of it, and I want to say, we communicate wonderfully with the CMOs. They meet with us weekly, and we've talked to the state about the issue. Somehow or another, the state, the CMOs, and us are not communicating effectively to take a hit list like we did. Many of you probably scream when I say this, ACS. I mean, Lord knows we had nightmares, but we started taking one thing off the plate and dealing with it. And we really haven't, as quickly as we move forward with trying to identify an issue like with the neonates, we've moved to a care management model now where the neonate's there 3 months and that's going to be projected plan. If we don't call every 2 days with the updated plan of care for that neonate, those days are denied. So if we hit our outlier status, then we have to go back and approve that. But part of what we're seeing is physicians. I can go back and bore you to death with all of our numbers, but contracted physician, hospital-based clinics where physicians are employed, maybe some of it's the issue where they're servicing several locations. They're not loaded appropriately in the system. We estimate an outstanding balance of about $1.4 million on those type physicians. We have the complete detail. We would welcome to sit down, and we have met with the CMO regularly, and we're slowly making progress, but there's a point where you can't carry this. We've got $100,000 on urgent care centers. We've got $1.6 million in incorrect or short payments. We have lab payments paid under the Medicare fee schedule that are Medicaid. There is just a list, probably pages, of just different small technical, 50 here, 100 there, that we need to sit down and resolve.
Well, I guess, as you say, you certainly can't deal with those kind of numbers, and I'm sure you can't. But neither can anybody else. I mean, if they have a 1% reduction in this, 34% reduction in how much money you get in that is very much of a concern, and not just only from your institution, but whatever additional information you could provide these two committees about the detail about how that happened. I mean, I want to be sure that this is not something that's,
Mr. Chairman, what you will find to Representative Chanel, we have someone from VHA that will be testifying that has been collecting this for like 24 hospitals, so they will have some more detail coming. These are just our numbers that we sent in related to that.
Representative Gardner has a question.
It's a grouper?
Pardon?
Other than a fish? You said something about a grouper.
I apologize. In January, the department, and I applaud DCH, they are moving toward updating the Medicaid grouper that they will pay our claims by. It's just the Medicaid payment system. And they will be moving to a newer version. And when they do that, we would assume the CMOs will be ready and they will pay accordingly. And we just want to make sure that with digging out from under this old, as we move to this updated payment system with new weights, that we're ready to go on the new stuff. We've got some time to plan. And I would say we volunteered to be a site for the Medicaid CMOs to demo remittances and claims and tests, and that never happened, and we still don't have electronic remittances that balance.
Thank you.
Thank you.
Wayne Seinfeld.
Thank you, Mr. Chairman, committee members, for allowing me to have permission today. My name is Wayne Senfeld, and I'm Director of Behavioral Health at Tanner Medical Center, an acute care hospital in West Georgia with one of the largest outpatient psychiatric programs left in Georgia today. I'm also here representing the Council on Psychiatric and Chemical Dependence Hospitals, which is comprised of 30 healthcare facilities statewide, along with other mental health experts. I personally have 25 years experience invested in schools and community counseling as well as treatment programs, and I come here today as an advocate and a citizen. I find myself in a quagmire working in a vocation that I've invested my life in, the service and treatment of children, adolescents, and adults in emotional pain and distress. I know that the very infrastructure and system that was designed to meet the needs of this vulnerable people is crumbling. Today, I guess I'm fortunate enough to be their voice. I'd like to speak to you today about the impact the CMO transition has had on mental health services in Georgia. Because in terms of potential treatment effectiveness, it could be the greatest of times. There's been phenomenal breakthroughs in the last 20 years psychiatrically. But in terms of infrastructure, availability, and access to mental health treatment and program, it's instead the worst of times. For Medicaid members of Georgia and for those persons seeking help, treatment, and new beginnings, it is no less than disheartening. I have great concerns in three specific areas regarding the CMOs. Number one, a lack of access to care for many mental health patients. Number two, the shifting of costs to other providers, both state and private. And three, unprofessional and unsupported clinical criteria. On a daily basis, I experience firsthand and hear from other providers about the CMOs denying access to treatment, effectively cost-shifting care to state agencies and divisions and private sectors such as emergency rooms, detention centers, juvenile and adult courts, state agencies, state hospitals. And it was my understanding that the CMOs committed to creating vast provider networks, increasing resources and choices for Medicaid members of Georgia, and developing a streamlined approach to health care access. But instead, I share a consistent frustration with providers who are miles away from impoverished Medicaid members with no transportation, or not accepting new patients, or not accepting children or adolescents, or have waiting lists 2 to 3 months long, or are not willing or qualified to work with the chronic patients that they are being referred to.